सर YouTube लाईव्ह झालंय.
ओके, चालू करूया आता. फक्त ते काळे सरांचं बघू. Okay, I spoke to Kale sir. He's joining in some time. I think we should start now. So good evening, everybody. Today is the first webinar of our 2025. Actually, we have missed one in January, which we have around the last week. So this one we have kept in the first week of February. So this is in continuation with our monthly webinar series. So today's topic is an interesting one on obesity. Some people may feel that obesity is not a good word, considering body shaming and all. So we have actually named it as patient with high BMI. And we have some excellent speakers who will share their experiences, some academics uh, uh, associated with this topic. So without wasting much time, I request the MOC of today's webinar, our dynamic member, Dr. Priyamvada. Can we have
Yes,
us,
sir.
please? Dr. Priyamvada is a MD anesthesia from Nair Hospital. She has been a senior resident at Tata Memorial Hospital for 2 years. And she was a faculty at the second and the third Yuva Mahakon and a faculty at ISACON Pune 2023. And she was our scientific secretary for the Yuva Mahakon, very successful Yuva Mahakon, which ISA Boruli conducted in 2024. So I request Dr. Priyamvada Deshmukh to take over and start the proceedings. She will start by introducing our two eminent chairpersons. Followed by that, we will have the sessions. Please continue.
Thank you so much, Dr. Rao, sir. Myself, Dr. Priyamvada Deshmukh, on behalf of ISA Borivali, in association with Society of Anesthesia, Maharashtra State, welcome you all for today's webinar. At the outset, it is our privilege to have our chairpersons with us, Dr. Pramod Kale, sir. Sir is a consultant anesthesiologist at Zen Hospital, Chembur, Mumbai. Sir has a vast teaching experience for more than 20 years for MD as well as DNB students. Sir will be joining us shortly. I would also like to welcome Dr. Reena Gautam, ma'am. Welcome, ma'am. Ma'am is a
एक minute यार.
Hello.
Ganesh, please mute everyone.
Yes, madam. Yes.
Ma'am is a consultant anesthesiologist in Navi Mumbai and Thane area. Madam's area of interest are pediatric anesthesia and geriatric cases. Ma'am is ex-treasurer, secretary and council member of ISA Navi Mumbai. Welcome, ma'am. We now move on to our webinar, Anesthesia Considerations in Patients with High BMI. I would like to welcome our first faculty speaker, Dr. Rashmi Valimbe, ma'am. Welcome, ma'am. Ma'am is a consultant anesthesiologist at KEM Hospital and Research Center, Pune. Ma'am has been contributing with her lectures and talks at many state and national level conferences. Madam's area of interest, anesthesia for bariatric surgeries and regional anesthesia. Welcome, ma'am. Over to you.
Hello, everybody.
Thank you, ISA Borivali, for giving me this opportunity. Uh, I would like to start my presentation. I would be sharing my screen now. Yeah. I would be talking about preoperative evaluation and optimization in morbidly obese patients. This is the declaration. Coming to introduction, so WHO defines obesity as a condition in which percentage body fat is increased to an extent in which health and well-being are impaired. Due to the alarming increase in prevalence, WHO has declared obesity as a global epidemic. It is a chronic progressive disease and results from multiple environmental and genetic factors. As of now, from 2022 census, the prevalence of obesity in India is as high as 43%. So this is the classification of obesity according to WHO, whereas various societies classify obesity in different manner. Like for Asia Pacific region, obesity they start to classify saying that the patient is obese right from a BMI of about 25. So I think maximum population attending this webinar is also obese. As we all know, obesity is classified classically in two types, pear-shaped and apple-shaped. So pear-shaped is central obesity, seen mostly in males, whereas apple-shaped is seen in females. That is more of subcutaneous fat and less of central fat, whereas pear-shaped is more of central fat and less of subcutaneous fat. So all obese patients have one of these or maybe multiple of these phenotypes. First is a normal weight obese person. Second is metabolically obese normal weight person. Third is metabolically healthy obese person. And fourth is the most problematic thing, that is the metabolically unhealthy obese person. And next is a sarcopenic obesity in these people, the muscle mass is quite less and fat mass is exceedingly high. So other parameters which we consider for classifying obesity is the waist circumference. That is according to US standards, they have said that in men, if it's more than, if the waist circumference is more than 40 inches, and in females, if it's more than or equal to 35 inches, then you should call them obese. Whereas for South Asian, Japanese and Chinese origin people, in males, it is more than 90 centimeters, that is 35.5 inches. And in females, more than 80 centimeters, that is 31.5 inches. Next is waist to hip ratio should be less than 0.8 to call a person as non-obese. Then waist to height ratio, that should be less than 0.5 if you want to classify yourself as non-obese. And last one is the skin fold thickness. So how do we measure body fat? So these are the various parameters what I talked about. These are the measurements in anthropometry. Whereas mostly we use the body mass index, but body mass index has certain disadvantages. Like a person may be more exercising more, and he may have more muscle mass, but still his BMI may be more. But that person is not an obese person. So that is a disadvantage of classifying obesity according to BMI. Then circumferences, as I mentioned, then skin fold thickness, then come the various machines and magnetic MRI, CT, then bioimpedance analysis, which we see in most of the gyms and nutritionists and obesity clinics. So this is how we calculate the fat mass. So coming to my topic, that is preoperative evaluation. So obesity is a multi-system disease, and it affects almost all systems in the body. So it causes sleep apnea, infertility in males as well as females, gout, high blood pressure, diabetes, cancer, coronary heart disease, gallstones, arthritis, and majority it hampers the quality of life of that person. So when do you evaluate a patient coming to you for for surgery? So if the patient is coming for elective surgery, then I would like to do a advanced PSC. Advanced PSC is something which is done at least 1 week prior to the surgery. So in the what do we do in advanced PSC? We take down the patient's personal details. We take down we measure all the anthropometry like height, weight, BMI, neck circumference. Then we note down whatever associated disorders the patient may be having, like hypertension, diabetes, hypothyroidism, or anything else. Then at that time, we also do the airway assessment of the patient. We note down any allergies. We note down whatever medications the patient is taking, whether the patient has any substance abuse issues, and whether the patient is using CPAP or BiPAP at home. So we take down the detailed history of associated disorders. The associated disorders most important for us are pertaining the respiratory system, because we want to ventilate the patient intra-op and then again make the patient breathe spontaneously at the end of the surgery. So in respiratory system, the main problems affecting us is obstructive sleep apnea and restrictive airway disease. Then coming to cardiovascular history system, we have to note down if the patient has systemic hypertension, pulmonary hypertension, right or left heart failure, ischemic heart disease. Now, if when a patient who's coming for bariatric surgery comes to you, comes to a surgeon for the first time, then that patient may most of the times comes with right or left heart failure. So we have to treat that heart failure first. The patient may have pulmonary hypertension, which may be secondary to his restrictive airway disease and obstructive sleep apnea. Then patient may be systemic hypertensive. Nobody has measured the patient's BP till now because nobody could find the appropriate size blood pressure cuff for that patient. So whatever the blood pressure is noted is almost 100% wrong in all cases. Most of the times the sister measures BP with some BP cuff which is available in the ward, or they don't measure and they just write 120/80 in all the files. So we have to measure the blood pressure of the patient by ourselves. Then the patient may be having GERD and hiatus hernia. Patient may be having diabetes mellitus, hypothyroidism. And most of these patients who are long-standing obese, they suffer from depression. They may or may not be taking treatment for this depression, but we have to ask for history. Even if the patient is not taking any treatment for depression, still we have to be careful around the patient. We should avoid any loose talk in front of the patient about his weight issues, about body shaming, about his size, or about anything pertaining to obesity. Most of these patients come with metabolic syndrome. What is metabolic syndrome? It consists of 5 parameters, and out of that, at least the patient must be having three, like waist circumference more than 102 in men and 88 centimeters in women. Serum triglycerides more than 150, HDL cholesterol less than 40 in men and less than 50 in women. Systemic blood pressure more than 130, systolic blood pressure more than 130 millimeters of mercury, or diastolic more than 85 millimeters of mercury, or patient is taking treatment for hypertension, and fasting serum glucose more than 110. So coming to the first comorbidity is obstructive sleep apnea. So this obstructive sleep apnea is a major problem. I have dealt with patients who, while I am taking PSE, while I am asking questions, they are sleeping and dozing in between. I ask them one question, then they doze, they answer, then they again doze off before answering my next question. So I have seen such patients also. So we have to be very careful about obstructive sleep apnea. It may be again central or peripheral. It is also called as obesity hypoventilation syndrome or Pickwickian syndrome. So what happens is usually the patients get up from their sleep during the night multiple times. So they don't get proper nighttime sleep. So they have early morning headaches. Then because they don't sleep properly at night, they are sleepy throughout the day. So whenever you see the patient is dozing off. So this leads to poor concentration, irritability, falling asleep during routine activity. We had a patient who had stopped driving and going to his office and had started working from home because he used to doze off while driving. So we have this is obesity hypoventilation syndrome is a major risk factor for accidents. The patient tends to doze off while driving also. Then they have frequent visits to bathroom at night, restless sleep. Again, they at night they have choking or they are gasping for air. The person who sleeps with them witnesses that the patient is not breathing in between, or he pauses, or he's breathing, he's making efforts, but the efforts are too much, and then the patient again wakes up suddenly. And obviously loud persistent snoring. So most of the spouses of these patients complain that I cannot sleep with this person because he keeps on snoring like anything at night. So why does this happen? So when the patient sleeps, there is loss of tone of the upper airway muscles. So there is partial or complete collapse of upper airway because of relaxation of muscles. So the air exchange either stops completely or is reduced to a great this thing problem. And at some time, the saturation falls to such level that the patient wakes up, and again he starts breathing properly. So again, when the saturation comes back to normal, again this same cycle repeats, and the patient again experiences hypopneas, apneas, and flow limitation. So apnea is complete cessation of airflow for more than 10 seconds, whereas hypoapnea is a decrease in airflow of at least 50%. And flow limitation is narrowing of upper airway, and is an indication for impending upper airway closure. So all this we study in sleep studies. So in sleep studies, they tell you about the apnea hypopnea index. So if it is between 0 to 5, it is normal. That means the patient has no obstructive sleep apnea. If AHI is between 5 to 15, then the patient has mild sleep apnea. If it is between 15 to 30, then patient has moderate. And if it's more than 30, then that means the patient has severe sleep apnea. Then how do we quantify obstructive sleep apnea? So this is stop bang questionnaire. We give this to the patient. So S stands for snoring, T stands for daytime tiredness, O stands for observed apneic spells, which is usually observed by the spouse or the person who sleeps with the patient. P stands for hypertension, B stands for BMI more than 35, age more than 50 years, and neck circumference more than 40 centimeters. And G stands for gender. That is, the sleep apnea is more common in males than females. So if the score is less than 3, then patient is usually low risk for sleep apnea. If 3 to 5, it's moderate, and if more than 5, then it is severe. Again, if stop, yes to 2 of stop and male gender, or if it is yes to 2 of stop and BMI of more than 35, or 2 of stop and neck circumference more than 40 centimeters, then again you classify it as severe sleep apnea. So coming to physical examination, so in this we take the anthropometry. We see whether the patient is drowsy or breathless. We ask the patient whether he suffers from breathlessness, whether he can walk for 15 minutes on flat ground, or he can climb two flights of stairs. Then we measure the blood pressure cuff with the appropriate size BP cuff. Many times we observe that a patient has conical arm and none of the BP cuff fits the patient. Then we can measure the patient's blood pressure with a normal BP cuff, placing it on a forearm. This is not true measurement, but it is for our reference. We can measure this as baseline and then keep the patient's blood pressure in that range during the intraoperative period. Also, it is very important to ask the patient whether he can lie flat in bed. If the patient is coming for something else, some other surgery other than bariatric surgery, say lower limb surgery, and you are contemplating to give the patient spinal anesthesia, then the patient must be first able to lie down in bed flat. If the patient says that I cannot lie down flat, then spinal anesthesia is out of question. How are you going to keep the patient after giving spinal if the patient cannot lie flat? Then we have to measure the oxygen saturation of the patient in lying down position and in sitting position. We have to see whether the patient has edema, mixed edema, or the patient may just have subcutaneous fat, which may be confused with mixed edema or pitting edema. JVP is almost impossible to measure because the patient has usually very thick neck. Then we have to also examine in detail the respiratory system. Cardiovascular system auscultation is many times difficult. CAD and history of angina you can ask, but again by physical examination it is very difficult to quantify. Pulmonary hypertension, these patients, most of the patients who have severe sleep apnea come to us with pulmonary hypertension. For these patients, we have to optimize the patient for at least 15 days to 1 month to bring their pulmonary hypertension to at least mild to moderate level. You cannot operate a patient when the patient's pulmonary or RV systolic pressure is somewhere around 80 or 90. Then the patient may be having maybe in congestive cardiac failure, which you have to treat. The patient may have obesity cardiomyopathy. That is, there is mechanical impediment to the biventricular function, or there may be myocardial fibrosis or fat accumulation in the myocardium, which may lead to all sorts of problems intraoperative. Then many of these patients have non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, or some patients may be having even cirrhosis. They because of the long-standing diabetes, insulin resistance, they may be having end organ diseases, nephropathy, then neuropathy. Patients may be having past history of stroke. Most common is DVT, because these patients don't move a lot, so they may be high risk for DVT. Also, because of the excessive fat accumulation, they tend to have DVT. And because of their chronic inflammatory state, also it pushes them towards DVT. Spine may be very difficult to palpate. These patients may be having prolapsed intervertebral discs. So giving spinal is also a challenge. Also, the depth from the skin to the posterior complex is increased. So you may require long epidural needles, long spinal needles, and it is not very easy to give neuraxial anesthesia in these patients. Airway, you have to document very nicely. Patients Malambatti grading, whatever it is, but the most important thing is neck extension and neck circumference. These patients are usually not difficult to intubate, they are difficult to ventilate. So it is always better to ventilate in RAM position. So you have to evaluate the airway very carefully. These patients may have, or most of them have no neck. They have heavy jaw, they have large breasts, so it becomes very difficult to manipulate the handle of the laryngoscope during laryngoscopy. So it is a good practice to use stubby handles, and it is a good practice to use McCoy blades for these patients for intubation. They may be very difficult mask ventilation, and you note down about the dentation. Coming to investigations, so we have complete blood count is necessary. Most of the patients have good hemoglobin levels. If you find a morbidly obese patients with low HB, then we have to evaluate for anemia, because these patients are having chronic hypoxia. So most of the times they tend to have a HB of higher levels. Then blood sugar and HbA1c, kidney function tests are mandatory. They may be having nephropathy and because of diabetes. Liver function tests are mandatory. On USG, somebody, because of the poor USG windows, the recorded finding may be grade 1 fatty liver, grade 2 fatty liver. And when the surgeon puts a laparoscope in, you will see a liver as I have shown the photo. So again, these 2D echo, USG abdomen, all these investigations you have to take with a pinch of salt, because of the poor echo window. You don't know whether whatever they have written is true, or it is little worse. The condition is little worse. Then a venous Doppler is must. Most of the patients are hypothyroid, so you have to get a thyroid functions done. It is a good practice to do a baseline ABG, so that we know the baseline PCO2 of the patient, so that post-operatively we can maintain the same. Polysomnography is not very commonly done, because all these patients we consider as severe sleep apnea. But for research purposes and for documentation, it is a good practice to do polysomnography test done. Risk of surgery, I think Dr. Parna is going to talk about it, so I think I'll skip these slides. Coming to optimization. So when the person first goes to a surgeon, he'll put a patient on low carb, high protein diet. He'll tell the patient to increase intake of salads, increase water intake, because they are in a chronically constricted state. So when you give antihypertensives, they tend to decrease the blood pressure very fast. Secondly, when you induce anesthesia, suddenly there is a lot of vasodilatation, and the patient suddenly goes into hypotension. So they should have a good water intake. Pre-operatively, you should keep the patient well hydrated. They have to stop alcohol intake before surgery, as it is their livers are bad. So you have to advise them strictly to stop alcohol. Walking and light exercises have to be started. And if the patient is posted for bariatric surgery, then pre-operatively, it is a good habit to make the person lose at least 10% of his weight. Otherwise, the patient may not tolerate bariatric surgery. He'll not comply with the post-op advice, and he may tend to regain whatever weight he loses. Respiratory system is the most important system for us. So the first and foremost is, if the patient is a smoker, tell him to stop smoking. Start good chest physiotherapy, deep breathing exercises, incentive spirometry, bronchodilatation. If the patient has low saturations, and if the patient is severe sleep apnea, start patient on CPAP or BiPAP. If the patient has pulmonary hypertension, in these patients, the pulmonary hypertension cure is oxygen therapy. If you remove hypoxia, the pulmonary hypertension tends to get better very fast. We have patients whom we have optimized in hospital, and we have brought the PA pressures from 80 to 40, and they have come from 80 to 40 within 15 to 20 days also, with proper oxygen therapy, CPAP, BiPAP. So whether you either you can advise the patient to go home with all this CPAP, BiPAP, and then come to you later, or you can admit the patient, optimize him, and then operate him, and then discharge. Better is to send the patient home, optimize him for 1 or 2 months, and then call him back, because then you tend to get better results. Then you have to give them the expectorant syrups for loosening of secretions. If the patient has a lot of secretions, if the patient is a smoker who has chronic bronchitis, then CPAP or BiPAP at home. And if the patient is using CPAP or BiPAP already, then you tell the patient to bring those machines to the hospital. They are used to their machines. So if they use the same machines in the hospital, they tend to comply better. And you have to motivate the patient for exercising, for following your diet, for following your medicine advice. If you advise CPAP or BiPAP in 2 weeks, usually the patients ventilatory, these patients have their hypercapnic ventilatory drive is gone. They do not respond to high CO2 levels. You can see patients coming to you with this, PCO2 of 60, 65 also, and they're perfectly okay, and talking to you, and they're awake. They only have their hypoxic drive patent. So in these patients, perioperatively, you should avoid bringing their saturations to 100%. You should maintain their saturation levels at whatever pre-op value they have been maintaining. So if the patient's pre-op saturation was 91, post-operatively maintain it at that level. Don't give the patient more oxygen, and don't try to bring the patient's oxygen saturation to 100%. So if you are using CPAP, in 2 weeks, the ventilatory drive becomes better. In 3 weeks, the ventilator ejection fraction and ventilatory function becomes better. And at 3 to 6 months, you see even reversal of pulmonary hypertension. So how do you optimize cardiovascular system? Treat the CCF with diuretics, reduce extravascular fluid, treat hypertension, optimize ischemic heart disease. Then stop antiplatelet therapy and start bridging with low molecular weight heparins. Treat pulmonary hypertension with oxygen CPAP, and if required, pulmonary vasodilators. And treat venous insufficiency and ulcers. Many patients have venous ulcers and venous insufficiency and DVT in the lower limbs. So it's very important to treat their DVT. Optimize blood sugars. These patients, their blood sugars don't tend to optimize till surgery. So we accept the patients at little higher blood sugar levels with insulin therapy. If the patient is hypothyroid, then treat their thyroid disorders. We use a deep vein thrombosis prophylaxis, and we use multimodal treatments. But what that is, we use pharmacological treatment in addition to mechanical, and we keep the patient hydrated. We use DVT stockings, and we use the DVT pumps intraoperatively, preoperatively, as well as postoperatively. If the patient is on antidepressants, then psychological stabilization plays a major role. If your patient is not stable psychologically, then it is not advisable to do a bariatric surgery, because he won't comply with the instructions, and then the possibility of having complications is much more. Lastly, avoid any loose talk in the periphery of the patient. They tend to the depression tends to worsen very fast. How do you pre-medicate the patients? Avoid any sedative pre-medication. No midazolam, no benzodiazepines, no tramadol pre-operatively. Let the patient be anxious, no problems, but avoid any sedatives. you may push the patient into respiratory type 2 failure with sedative. So avoid all sorts of sedatives. Give good gastric acid prophylaxis. They tend to regurgitate. So you give good gastric acid prophylaxis. Continue antihypertensives except for telmisartan, losartan, because they cause precipitous fall in blood pressure after induction. But beta blockers you continue perioperatively. Stop all oral hypoglycemic agents and convert the patient on short-acting insulin preoperatively. Post-operatively, this patient's blood sugar comes back to normal very fast. So monitor the patient blood sugar levels intraoperatively and post-operatively. Continue thyroxine if the patient is hypothyroid. If the patient is on antidepressants, then continue the antidepressants. Also, if the patient is on antidepressants, you have to be careful about the drug interactions with fentanyl and ketamine. So keep that in mind. So now your patient is ready to be wheeled in the operation theater. So so Priyamada madam can
Yes,
take
ma'am.
over.
Thank you so much, Rashmi ma'am, for such practical points about the optimization. And now we all know the importance of advanced PAC is very clear to each one of us. Thank you, ma'am. So the queries or the doubts will be taken at the end of the second talk. So you can post your doubts in the chat box. I would now like to welcome our second speaker, our very own Dr. Shilpa Tiwaskar ma'am. Welcome, ma'am. Ma'am is a consultant anesthesiologist at Bhakti Vedanta Hospital and Research Center. Madam is governing council member of Society of Anesthesia Maharashtra State Chapter. Madam has many awards to her credit. And Madam is going to talk on intraoperative ventilatory strategies and the extubation criteria in patients of high BMI for non-bariatric surgeries. Welcome, ma'am. Over to
Thank
you.
you so much, Dr. Priyamada. Yeah, are my slides seen?
Yes, ma'am.
Yeah. So intraoperative ventilatory strategies and extubation criteria for high BMI patients. Hope I am able to convey the gist of my talk is mode of ventilation. Today, what will be our goals of discussion? Once a patient comes for anesthesia, what should be our mode of ventilation? How we should maintain oxygen saturation. As Dr. Rashmi madam has said, no need to make it 100%. Let's see how much percent is good then. And troubleshooting. If intraoperatively there is increase in airway pressure or tidal volume or EtCO2, then what do we do? What most of us forget is that whatever our intraoperative care that we take also affects the patient's postoperative pulmonary complications. Also, we do not discuss, we just discuss under spinal or under general anesthesia. We should also discuss a obese patient for total intravenous anesthesia on spontaneous or controlled and with laryngeal mass airway. Yeah. So now there are animosities. How much low saturation to accept? Someone says 93% on GA is okay. I'll say, okay, I'm happy with 95. I don't want below 95. How much air pressure to accept to prevent rupture? Sometimes the monitor says the anesthesia workstation has limit of 40, but then we have seen bulle rupture at 38 also. Then how much PEEP is optimal? Someone will say 6, someone will say 12. How much EtCO2 to accept? We have to accept high EtCO2, but how much? 45, 50, how much? And whether to extubate patient or send on TPs or laryngeal mass airway. So my flow of topics will be, I in short talk about the pulmonary dynamics, the terminologies, the PaO2 and the FiO2, the selection of ventilatory strategy, which is the gist of my talk, mode of ventilation, PEEP, recruitment maneuvers, Is to E ratio, tidal volume, FiO2, troubleshooting, and extubating strategies. Now, the pulmonary dynamics. We all know what is functional residual capacity. It is the volume of air which is remaining in the lungs after tidal exhalation. Now, why it is important? Because this FRC will keep the alveoli open. If you see in the figure, now as we make our patient supine, a normal supine patient, Okay, so his diaphragm level already goes behind. So his functional residual capacity, the volume which will keep the alveoli open, decreases. Then further, if you see, again with induction of anesthesia, again the functional residual capacity further decreases. Then once we give paralysis, it further decreases, and for an obese patient, it decreases further. If you see on the right side, what happens in obesity, the functional residual capacity decreases, the C lung, that is the lung compliance, decreases, and the resistance of airway increases. Now, why lung compliance decreases? If you see in an awake patient, the intercostal muscles, they will push the thoracic wall outside. The spine will keep the chest wall taut. And of course, the lung compliance, which will be pushing inside. But once we give general anesthesia, what happens? The thoracic wall relaxes, so that it will be pressing on the lungs. The obesity, the fat will be pressing on the lungs, plus the spine relaxes. So here we have everything which is decreasing the lung compliance, and hence what happens? If you see in obese patient, obese anesthetized patient has very less functional residual capacity to keep the alveoli open. And the worst position is when you make the patient supine, give general anesthesia with paralysis, and give Trendelenburg position. So till now, we have seen that the FRC, which is there in obese patient, which determines to keep the alveoli open, is very less, and especially under general anesthesia. This figure we all know, when we make the patient supine, there is always a VQ mismatch. The upper part will get ventilated good, but the blood supply will be more to the lower part. So of course, in obese patient also, we have this VQ mismatch. There's an advantage of prone position. We see in supine position, the upper alveoli get stretched at the apex and the lower get compressed. But as soon as you make the patient prone, the upper apex alveoli, which were already bigger, they remain bigger, but the lower base alveoli, which were compressed, they start increasing in size. And hence, prone position is good even for the normal patients and obese patients. So we have finished the pulmonary dynamics that we require for obese patient. Now, one terminology which you will see continuously is that the ratio of PaO2 to FiO2 should be good for obese patient. What does that mean? Now, if a FiO2 is 25%, that means if I'm breathing room air, say 21%, and if I do an ABG, my PaO2 on ABG is 96. That means my PaO2 to FiO2 ratio is 384. And hence, above 300, anything is good. I am not in respiratory failure. But suppose I'm giving a patient FiO2 of 60%. And when I do ABG of that patient, then PaO2 comes 65. Then my PaO2 to FiO2 ratio is 65 upon 0.6, which is 108, which implies that the patient could be in respiratory failure. Now, why it is going to imply? The implication is that how much oxygen we are giving to an obese patient and whether that is getting transferred to the blood to maintain his oxygen saturation. Now, selection of mode of ventilation. One of my senior in our scientific group has written, I remember this is for her actually, she's not attending, that who will tell us what is right, which mode to use. Normally, we write our references at the bottom of the slide, but here I have written so that we know how we have evolved using different modes of ventilation for the obese patient. Initially in 2008, we saw that they said that pressure control ventilation was more important. They thought, see, there were two schools of thought, that volume control ventilation will eliminate carbon dioxide better, but pressure control ventilation will keep the alveoli open by deceleration flow. This deceleration flow, here I have tried to explain. Suppose my respiratory rate is 15 breaths per minute. That means 4 seconds each breath. So 1.3 will be my inspiration. If I'm using volume control, in that 1.3 seconds, my tidal volume will come. But if I am using a pressure control ventilation, then in that 1.3 seconds, the flow will slowly rise and slowly decelerate. And hence pressure control ventilation was thought good for obese patients. But the further references say that instead of pressure control ventilation, we use a volume control ventilation with low volume, 6 to 8 ml per kg, lung protective, plus two main important things came into picture. That is alveolar recruitment maneuver and PEEP. That means if you give PEEP at the end of expiration and in between every 30 minutes, if you recruit the alveoli, then that is more important. Again, in 2015, they said that volume control ventilation plus higher PEEP will help the patient. But how much higher PEEP? Let's see. In 2015, they again said use low tidal volumes, use PEEP of 8 to 15, recruitment maneuvers during the intraoperative period, and judicious use of oxygen. Why? Because high oxygen is going to cause absorption atelectasis in these patients. Also, it will cause oxidative stress to the patient. Now, one take-home message, if I have to give through my talk, then it is do not forget to use recruitment maneuvers. Recruitment maneuvers should be used in each and every obese patient and normal patient, but do not forget it obese patients. Again, in 2018, there was a big trial, the PROBEASE trial. They used the grade principles. They defined the mode of ventilation, how is the hospital mortality, the intraoperative gas exchange, the intraoperative respiratory intra and postoperative respiratory complications. In 2019, again, they concluded that these patients should be ventilated with volume control PEEP and alveolar recruitments. Similarly, again, we had into 2020 that there is no difference. Why are we looking at all this history? So that we know that we have to ventilate these obese patients with low tidal volume according to the ideal body weight, give PEEP, use recruitment maneuvers. Again, 22, they said that PEEP IND, that is individualized PEEP, don't use common for all patients. But do you know that individualized PEEP has to be calculated with complex instruments, and hence we usually measure PEEP from 6 to 12 centimeters of water. So these are the various studies which have trials which have taken place to determine what mode of ventilation to be used. Now here, till now, we saw at least 8 references, major references, which said use volume control. Then came a study which was there done in 2017, which said that pressure control with inverse ratio ventilation. Basically what? Normally we use 1:2, right? Inspiratory time 1 and expiratory time 2. We might feel that for obesity, it might take longer time to expire. No, the obesity is a restrictive type of lung disease where it requires more inspiratory time for alveoli to remain open. And hence, we have sometimes they say instead of 1:2, we can inverse the ratio to 2:1. So here there was a terminology which was introduced, that is pressure control and pressure control inverse ratio ventilation or pressure control ventilation with volume guarantee. Basically, remember that you have to control the peak pressures, you have to control the PCO2, and these obese patients, they have some inflammatory response within the airway. They have change in configuration of the markers, the TNF alpha, the SPA. So there is some inflammation, low-grade inflammation, which these obese patients have. So now let's see how do we do the recruitment maneuvers. A small video of how we do the recruitment maneuvers. So this is a patient who is getting volume control. Now I'm changing the mode to pressure control. Instead of putting to 40, I have kept the pressure I will again decrease it to 38 centimeters of water, and I have given a PEEP of 8. No pressure support. Now, total breaths were 15. So I will at least now I'm calculating the breaths according to the EtCO2 graph, right? So this is third breath, the fourth breath, the fifth, the sixth. So I have to calculate at least for 30 to 40 seconds. If you would have noticed, my compliance was 18 initially, which has become, which is nearly touching 25, and my tidal volume has increased for that much period. So now again, I have to put on volume control and decrease my tidal volume. So remember to do this recruitment maneuvers every 30 minutes. It will definitely improve your oxygenation and ventilation and prevent post-operative pulmonary complications. Again, same. Okay, now in between, there was a question mark whether this recruitment maneuvers at 38 to 40 centimeters of water for 10 seconds, 15 seconds, 40 seconds. See, if I'm doing half the respiratory cycle, it comes to 30 to 40 seconds. So whether it will cause any rupture of alveoli or cause any bulle rupture. So initial studies said that PEEP of 5 centimeters of water improved diaphragmatic exertion and lung aeration more, and not statistically significant if you give PEEP more than 5 centimeters, and recruitment maneuver of 40 millimeters of 40 centimeters of water are good. Recruitment maneuver in laparoscopic sleeve gastrectomy surgeries. So all these references say that using recruitment maneuvers at that pressure is good. Alveolar recruitment maneuver results in improved pulmonary function in obese patient. The latest study, which says that effect of intraoperative recruitment maneuver in patients with obesity undergoing laparoscopic surgery, a narrative review, they had used pressures up to 40 centimeters of water for 15 seconds or 40 seconds. And they say that it does not cause any rupture of bullae. They are safe and they do not have any unfavorable hemodynamic consequences. So what I do is I adjust the pressure to 38 millimeters of mercury, give PEEP of 8, count at least 8 EtCO2 graphs, and then I change it back to volume control mode. Now, if there is an episode of bradycardia, you may give glycopyrrolate, or you wait. Once the maneuver is over, it will revert back. If there is 20%, like once I had blood pressure falling to 66 systolic. So if you have 20% decrease of mean arterial blood pressure, then you need to give fluids to the patient if the 2D echo is normal, if the patient is not in cor pulmonale. So contraindications for this recruitment maneuver: hemodynamic instability, emphysema, cor pulmonale, increased intracranial pressure. Now most of us private practitioners, we may not have high-end anesthesia machines. So how do we judge? How do we give this recruitment maneuvers? You can just do compression or squeezing of the back, but only disadvantages. If you don't have PEEP, then once you release the squeezing of the back, again the alveoli tend to collapse. But whatever it is, even with squeezing of the bag is okay, but try to give recruitment maneuvers. Now, PEEP. What PEEP should be ideally used? So, PEEP of initial settings, 6 to 12 centimeters of water, they have said is the ideal PEEP we should be using. Don't increase suddenly. You have to increase it stepwise. And the pressure required to recruit the lungs is larger than the pressure which is there, which tends to collapse the lung. Hence, giving PEEP is necessary. Again, peak inspiratory pressures. Basically, they have tried to find out which PEEP is ideal. And PEEP has to be calculated according to the transpulmonary pressure, not just the peak plateau. The peak plateau as well as the pulmonary pressure, that is the pleural pressures which are there. Now comes the IE ratio. I already have talked about it. The IE ratio, since it's a restrictive pulmonary disease, the I ratio can be 1:1 to improve the alveolar oxygenation. And by giving this I ratio 1:1, there were no statistical difference in the mean arterial pressure, heart rate, respiratory rate, end tidal carbon dioxide, and partial pressure of carbon dioxide. Now, effects of ventilatory strategy on arterial oxygenation and respiratory mechanics. Here again, they have compared 1:2 and 1:1. So they have said that changes in partial pressure of carbon dioxide were significantly important in 1:1 ratio. So all these evidences are regarding the ratio of IE ratio 1:1. Again, selection of IE ratio. Now, inspiratory to expiratory ratio should be adjusted according to the patient's physiology, ideally 1:1. But suppose if the patient has added chronic pulmonary obstructive disease, then you may change it to 1:3. Now, the minimum oxygen saturation. Sometimes the saturation on monitor shows 94% and we say it's okay for obese patient. So how much should we accept? Studies have shown that minimum oxygen saturation acceptable is 95%. And FiO2 should be in the range of 40 to 80% if obese patient is recommended. Now, we agree that the oxygen requirement is high because of the adipose tissue and pushing of the diaphragm by the abdominal contents and decrease of the FRC, but FiO2 should never be 100 because it will cause absorption, atelectasis, and oxidative stress to the lungs. This is a rough chart. If you are not doing ABG, then you should know when your monitor shows saturation of 94%, that means the PaO2 is 73. And hence, we usually accept PaO2 of 80 with saturation of 95. Permissive hypercapnia. Again, how much is good? Intraoperatively, there are surgical loads which increase carbon dioxide. Also, there is increased metabolic demand for obese patient. Compromised respiratory dynamics are there, and hence, mild hypercapnia with EtCO2 of 50 millimeters of mercury without hemodynamic compromise can be accepted. So again, carbon dioxide, okay, we have to remember that when we accept hypercapnia of 50 millimeters of mercury, remember once the Trendelenburg position or any other or pneumoperitoneum is removed, the return of carbon dioxide to normal levels takes a lot of time, and it is important before reversal that we return it to the value which was there before giving the pneumoperitoneum or Trendelenburg position. So just as a revision, we all know tidal volume of 6 to 9, positive pressure of 6 to 12, recruitment maneuver must, where you keep the pressures up to 40 centimeters of water and for 10 to 40 seconds. P plateau 26 to 30. Okay. Now this is in ICU, they follow for obese patient, the I star. Okay, this is most important. When should an obese patient under general anesthesia be kept on spontaneous breathing? Remember, the obese patient have reduced FRC, increased airway resistance, increased lung or decreased lung compliance, and hence their increased effort to breathing, risk of atelectasis, risk of potential oxygen desaturation. Hence, the obese patient should not be kept for a longer time under general anesthesia and spontaneous breathing. If at all you have to keep, then you have to use pressure support ventilation with P. These procedures such as dilatation curettage, all these procedures where instead of an airway, you can put an LMA just to prevent tongue fall, or so if you have to give pressure support ventilation with P. Now, can LMA be used for controlled ventilation? Only for shorter procedures, not for procedures exceeding 1 hour. Because again, because of the decreased pulmonary resistance, increased pulmonary resistance and decreased pulmonary compliance, ventilation will be difficult. The airway pressure will start increasing and the EtCO2 will start increasing. Okay, the case scenario. A female, so I'll be concluding in another 5 minutes. Yeah. So the case scenario, female 45-year-old, 124 kg, 150 centimeter height for laparoscopic hysteroscopy. Saturation of oxygen preoperatively was 99 on room air. After, I think it should be laparoscopy, hysterectomy. Okay, hysteroscopy. So after it is hysterectomy, this patient had come for laparoscopic hysterectomy. So after intubation, Trendelenburg position and pneumoperitoneum, the saturation fell to 93%. What will you do? What is our first response? Will you increase the FiO2 from 0.5 to 0.8? Will you increase the tidal volume? Or tidal volume you feel was delivered less and hence you are increasing? Will you increase the respiratory rate? Will you increase the PEEP or will you change the mode of ventilation? Now, which of the above maneuver is unnecessary? Increasing FiO2 is unnecessary. Changing tidal volume just arbitrarily, even if it is getting delivered, just increasing to increase oxygen levels is unnecessary. And change to pressure control mode arbitrarily without any reason is unnecessary, unless there is increase in peak pressure. Now, with which maneuvers the saturation, with all these maneuvers that you have done, the saturation has come to 96. Will you accept that or do anything further? We'll do the recruitment maneuvers. A 65-year-old male patient, 104 kg, 156 centimeter, was for laparoscopic cholecystectomy. Saturation of oxygen preoperatively was 97% on room air. After intubation, the ATCO2 was 37. After reverse Trendelenburg position and hemoperitoneum, even in reverse Trendelenburg position, the ATCO2 increased to 47 millimeters of mercury. What will you do? Will you increase the PEEP? Will you increase the respiratory rate? Increase the IE ratio? Increase the tidal volume? Change to pressure control ventilation? Change to pressure control ventilation with increasing the PIP. Now, which maneuvers would be wrong? Never try to increase the IE ratio more than 1:2 and never change to pressure control ventilation with high PIP of 38. Which maneuvers the ATCO2 dropped to 44? Give recruitment maneuvers, and which maneuver was unnecessary? Increasing the tidal volume. Extubation, I would just, these are the general criteria for extubation. This we all do. Check there is no bleeding, no trauma, no airway edema. Keep a bite block. Remember that we don't allow the patient, even the obese patient, to bite on the tube. It can lead to forced inspiratory efforts, can cause pulmonary edema. Now, what would you do, especially for an obese patient? The patient should be awake, should have eye opening and obeying commands, should not be under sedatives. Alveolar recruitment maneuvers should have been done. If not done, you can do now. ATCO2 should be less than 50. Check if SpO2 is more than 95 on FiO2 of 0.4.
Hello.
Ganesh, can you mute everyone? So check if SpO2 is more than 95% on FiO2 of 0.4. So now, how do you make FiO2 of 0.4 when you are giving oxygen by circuit? Dr. Pragnesh, can you please mute yourself? Ganesh, तू आहेस का? Okay, so check if SpO2 is more than 95%. How do you do that? Either add air in your flow meter or you open the circuit to the catheter mount to air so that you don't give 100% oxygen and see that if the patient is maintaining oxygenation with saturation more than 95. Respiratory rate should be normal. Now, I don't know how many of you do, but I do even for a non-obese patient. When the patient starts breathing spontaneously, I close the APL wall to 5 to 10 centimeters and let the patient breathe against the resistance, against the continuous positive pressure, so that they take a effective tidal breath. Head lifting, initially what we all did as PG students, it has false positive, false negative. Hence, you have to combine. It is not that it has become obsolete, but you have to combine with eye opening, tongue protrusion, and hand grip. Of course, the gold standard would be the TOF ratio more than 0.9. So gamma dex is preferred. Hemodynamic stability should be confirmed. There should be no hypothermia. Also, standby, you can keep high flow nasal oxygen or you can keep Thrive, and One more thing which has come latest is you can mark the cricothyroid membrane and keep it with a marker. Remember, you have to mark it in full extension so that post-operatively, after extubation, if there is any problem, you can re-intubate. Readiness for extubation, again, all things should be available. In reverse Trendelenburg position, you have to extubate. If the patient has OSA history and already on CPAP, then keep it ready. Patient will require it. Or you can, before extubation, you can put an LMA, Bailey's maneuver, and then try to keep the patient on slowly, wean off the patient on LMA. Of course, the cuff leaf test, which we all do, check whether after deflating the cuff, the patient is taking a good amount of breath. Only at this point of extubation, you can increase your FiO2. After you confirm that with FiO2 of 0.4, your patient maintains saturation of 95, then only you pre-oxygenate before extubation. Your backup plan should be ready. All your difficult cards should be ready. Oropharyngeal, nasopharyngeal airway should be ready. Always check on spontaneous. If you have anesthesia machine, how much tidal volume the patient is generating, and check that the patient does not have paradoxical breathing. This is the DAS guidelines. What you have to do is low risk patients and at high risk patients. So at high risk patients, they have said that you either extubate on a laryngeal mass airway or you put a airway exchange catheter. The another one more technique is switch off propofol and sevoflurane much before and start remifentanil infusion, and you can extubate the patient on that. Airway pressure release ventilation, which is one of the mode which is used in ICU, where peak pressure can be given at 2 levels when the patient is inspiring and at the end of inspiration. So my take-home message is, for an obese patient, however small or big the surgery is, my choice of anesthesia and everyone's choice of anesthesia should be general anesthesia with endotracheal tube. Volume control mode is the preferred mode with PEEP and recruitment maneuver. Continuous positive pressure, which now Dr. Parna and Dr. Kalpesh will say pre-operatively, then intraoperatively, you have to use recruitment maneuvers, and post-operatively for extubation. NIV should be kept ready. Emergency plan B should be ready post-operatively. And LMA should be used as an airway and a rescue maneuver and not for routine anesthesia. Thank you. Hope I did justice to the topic.
Thank you so much, Shilpa ma'am. That was a very elaborate talk, and many points are clear after hearing to you, ma'am. Thank you so much.
Thank you.
We have a few questions, I think, to Rashmi ma'am, but ma'am has already answered that in the chat box. But still, for all of us, there's a question to Rashmi ma'am. Ma'am, what basic minimum investigations would you advise in emergency surgery in a patient with high BMI?
Yeah, actually, if it's an emergency surgery, the most important is ABG. Get a ABG done so that you know the oxygen levels and the CO2 levels. Then we get a CBC as routine investigations. Then we have to know blood sugar levels and serum creatinine, whether the patient has any end organ diseases. And ECG and 2D echo are very important because most of these patients have some sort of coronary artery disease, hypertension, cardiovascular problems, and we have to assess the fluid status of the patient. You have to keep the patient hydrated at all times. The more dehydrated patient, the more the risk of DVT and all the problems related to hypertension, DVT, and ischemic IHD. So you have to always keep the patient hydrated. So 2D echo is one of the most important investigations.
Yes, ma'am. And ma'am, one more question. Is anti-thrombotic prophylaxis mandatory for patients with
Yes,
high BMI in all the surgeries?
these patients have are in a prothrombotic state. Their CRP is always increased. They have a low level inflammation continuously going in their body because fat is relatively less supplied by blood. So the central part of fat is little ischemic, and there's a continuous inflammatory reaction going in that fat. So their CRP is always increased. So this always leads to prothrombotic state. So all these patients have to have antithrombotic prophylaxis perioperatively if the patient has to undergo any surgery under anesthesia. And plus, with all the different positions with the surgeon gives, sometimes extreme head up, sometimes extreme head low in laparoscopy. For bariatric surgeries, there is extreme head up. For other gynecological surgeries, there is extreme head low. So, keeping all these positions in mind, it is always better to have a antithrombotic prophylaxis for the patient perioperatively.
Yes, ma'am. Ma'am, I request Dr. Reena ma'am for her inputs.
Both the talks were really very good. Everything was literally covered. Shilpa ma'am, I would suggest, will it be advisable to go for progressive recruitment maneuvers rather than sudden the recruitment, adjusting the pressure? Ideally, what do you do?
That means you mean to say initially less few seconds and then more seconds?
Yeah.
Yeah, so there are two schools of thought. Either you put the pressure at 40 and use it for 10 seconds. Some say use it for 15 seconds. Some say use it for 30 to 40 seconds. So giving it suddenly for 8 breaths, that is 30 seconds, is also good. That's why actually my references were there that it will not cause any rupture or any harm. So giving at 40 seconds, 30 to 40 seconds at 40 millimeters of mercury is also good.
Actually, I'd like to add something. If we give a progressive, we start with a higher PEEP. We keep the PEEP at 10 to 12 centimeters of water, give 4 to 6 breaths, then decrease PEEP for up to 10, give 4 to 6 breaths, then decrease it to 8, give 4 to 6 breaths, and then decrease it to 6 or 5 or whatever level you want to keep throughout the surgery. Then you have a very good recruitment and the patient's saturation tends to remain constant throughout. So progressively, first you start with higher PEEP and then come to whatever PEEP you want to keep throughout the procedure. This helps a lot.
So this is your experience because in my experience, I always start with 5 PEEP and then slowly we increase it to around 8. And if required, hardly any 10 PEEP is required.
I
And
don't
even
keep
the
that much
literature
PEEP.
says that PEEP should be always stepwise. So
Yeah,
like
I don't keep that much PEEP. I only do recruitment and then bring down the PEEP to 5 or 6. Most of the times, 5 to 6 centimeters of water PEEP is adequate.
yeah. So but then why you start with high PEEP? I didn't get
Only
you.
for recruitment maneuver. Only at
Ah.
high PEEP, only 4 to 6 breaths and I come down to 5 or 6. Only for recruitment.
Okay,
Then
okay,
on, I
okay.
continue with 4 to 6 centimeters of water PEEP.
Okay.
Thank you, ma'am. Ma'am, one question for Shilpa ma'am. Why the eye ratio? Is there any specific reason that why the eye ratio should not be more than 1:2 in obese patients?
In the obese patients, the alveoli collapse. So hence the inspiratory time should be more. The functional residual capacity is decreased because of the chest wall pressure, because of the pressure from the diaphragm. Also, as Rashmi madam said, as we know that the lung compliance itself is decreased. The lung blood volume is more. The lung has an inflammatory state. Plus there is this thrombotic state is there. So the lung volume is increased. There are pressure from the chest wall, pressure from the diaphragm. So now here we are fighting to keep the alveoli open. In that, if you decrease when 1:3, when we say, that means the inspiratory time is getting decreased. So the alveoli will start collapsing. The whatever we are giving either pressure control or volume control, the alveoli will start closing early. And hence there will be more difference in the EtCO2 as well as oxygenation. So 1.3 is really not good for the patient. You have to keep either 1:1 or 1:2. For morbidly obese, we keep 1:1.
Yes, ma'am.
Also, I would like to add, nasopharyngeal airway is a very handy device during extubation. It is comfortable for the patient. Patient is more compliant with the nasopharyngeal airway and it maintains the upper airway patency. So, before extubation only, you insert a nasopharyngeal airway and then you extubate the patient so that the post-op oxygenation is better maintained and the upper airway patency is better maintained.
Yes, ma'am.
Agree.
Thank you, ma'am. So, as we move forward, we have two interesting case presentations in patients of high BMI. So, first, I would like to welcome Dr. Prajakta Kulkarni, ma'am. Welcome, ma'am. Ma'am is a consultant anesthesiologist in private practice for more than 20 years. She's also working in Cloud9 Hospital, and she'll be sharing her experience in a patient of high BMI. Over to you, ma'am.
Hello, am I audible?
Yes.
Yes.
No, I am not seeing. Hello,
Yes, ma'am.
hello.
Yes,
Is the
ma'am.
screen visible?
Yeah, yes, ma'am, please. Yes, ma'am. Continue.
Yeah. So good evening, everyone. Respected seniors and colleagues. I'm happy after hearing the first two talks that I think I did my case pretty well. So today we are discussing about the high BMI patients, and whatever cases I have done, whether they are for bariatric surgery or they are for other laparoscopic surgery. The thing is, I try to follow the protocol for the pre-operative evaluation and optimization, intraoperative strategies, and post-operative management. So that this is just so that we should not necessarily that we carry out everything in each patient, but when you have the checklist, you don't miss anything. That is the point behind it. And so whatever cases we do in Cloud9 Hospital, also high BMI patients, we try to investigate them like this. Now this patient, if this case was 31-year-old female, posted for mini gastric bypass. The patient's height was 172 centimeter, weight was 181 kg. So her BMI was 62.4. So according to surgical literature, she was under the category of super obese patient for mini gastric bypass. So on when I visited her for a pre-anesthesia checkup a week before the case was told to me, there was no history of any surgery in the past, no history of any comorbidities like hypertension, diabetes, or anything. She denies the history of addiction, no history of any known allergy. She was just a known case of hypothyroidism since 10 years on tablet Tylenol for 100 milligram OD. The pre-operative investigations which were done, like complete blood count, LFT, RFT, thyroid function test, lipid profile, coagulation profile, triple H, blood group, cross-match, HbA1c, urine, X-ray chest, ECG, 2D echo, OGD-scopy, and sleep apnea study was done. Sleep apnea study, the AHI score was 26, so she was in moderate category of sleep apnea. And when I went examine her, same way like the height and the weight, then the veins could be seen properly. So I was very happy. The Malampatti classification was 2. Neck circumference was 35 centimeter. Stop bank questionnaire was carried, asked that questions. According to that sleep disordered breathing, her score was 4. So she was definitely a high risk candidate for post-operative support. She was advised intensive, actually BiPAP, but she did not do it. So incentive spirometry for 5 days she had taken, and of course by surgeon, liquid diet for 5 days. That's how we took her in OT. And in OT, when I took her, I just started with pre-oxygenation with nasal cannula. Then multi-parameter monitor was attached, pulse, blood, NIBP, the good BP curve was available. Then ECG, ETCO2, 2 IV lines were secured, DVT pump was attached, Foley's catheter inserted, difficult airway cart was kept ready. Then I took her for a pre-medication, took her on mask ventilation. The pre-medication was given with glycopyrrolate, Emisate, Perinom, Pan40 and antibiotic. The sedation, the drugs used are, few drugs we use are the dosages are based on ideal body weight of the patient, and few drugs on total body weight of the patient. They're depending on the lipophilic concentration of the drug. So the thing is, for fentanyl and midazolam, we use actually total body weight of the patient. So fentanyl was given 150 microgram and midazolam slowly was given 2 to 3 milligrams slowly. The mask ventilation was not difficult. It was well possible, but then I gave the propofol 150 milligrams slowly. Though mask ventilation was possible, I put LMA number 3, then injection and ventilated her with 100% oxygen. Injection vecuronium I chose because I could ventilate well with the mask. 8 milligram vecuronium was given, ventilated for 2 to 3 minutes. Then the LMA was removed and 7.5 number endotracheal tube was placed. Intubation was easy. Proper positioning of is given to the patient, giving supports from all the sides and padding the pressure points. For maintenance, I use oxygen, nitrous oxide, sevoflurane, and volume control ventilation. Tidal volume 650 ml, respiratory rate 16, I ratio 1:2. I use PEEP of 10. Intraoperatively, recruitment maneuver was done every 45 minutes with the hand, bag ventilation with the hand. They were then intraoperatively, all these parameters were well maintained, like saturation was maintained between 95 to 100. ETCO2 was maintained between 40 to 45. And throughout the surgery went for around 4 hours, but I could maintain the patient well throughout the surgery. Reversal was given with Sugamadex 400 milligram, and the patient was extubated. Patient was wide awake. I put nasal airway and high flow oxymask. Observed that patient in OT for 30 minutes, then shifted to ICU. In ICU, ABG was done. That was showing some respiratory acidosis. So I kept her on BiPAP overnight. DVT prophylaxis was given injection Trixan. For pain relief, I use injection paracetamol per 100 milligram tramadol drip 30 minutes before extubation, and butorphanol patch 20 milligram was applied. Next day, visited the patient, and the patient was fine, to my luck, and awake and ready for ambulation. Thank you.
Thank you so much, Prajakta ma'am. Ma'am, the weight was 180 kg. That's really
Yes,
scary.
that
But
was scary.
yes, ma'am. I
But
think
luckily, that patient was 31-year-old young female and without any comorbidities.
yes, ma'am.
That was so I could do it, I think, maybe.
Yes,
We have to optimize the patient according to the comorbidities.
yes.
Here it was only the weight was the problem. She was young patient and without any comorbidities.
Yes. Any questions we can take after the second case presentation? Is that okay, Prajakta ma'am?
Yeah.
Thank you, ma'am. I would now like to welcome Dr. Anees. He's a consultant anesthesiologist at Millat Hospital and also attached to Wadia Hospital. He will be sharing his experience in a patient of high BMI. And over to you, Dr. Anees. You can share your screen.
Hello, am I audible?
Yes, sir.
Okay, good evening to everybody.
Good evening, sir.
Hello,
Yes, sir. We can hear you.
is my screen being shared?
Yes, yes, sir.
You all can see? Okay. Are you able to see?
Yes, sir.
Okay. We will start in a while. No? Let me just put this on the slide to show. Okay, shall we start?
Yes, sir.
Okay. So good evening, everyone. My name is Dr. Anis Manikangani. I am a consultant anesthesiologist and a chronic pain physician at Millet Hospital, Mumbai. So I did this one case where the patient was morbidly obese. So let's start. So just before starting, I just want you to know about the little trivia. If you've heard about this man who was around 364 kgs and 6 feet 2 inches tall, and uh, he was a very famous sovereign activist, also a musician and entertainer. Uh, but why I'm sharing this because he was famously called as Brother Is, and he unfortunately died at the age of 38 because of his obesity and many comorbidities that he had. So obesity, as we know, it is WHO also has defined it as an excess body fat to the extent that health and well-being are adversely affected. So these days, the last few years, we had this COVID. Nobody was talking about obesity. Obesity is an equal threat globally that we should know. It's of course a disease. And meanwhile, the children in Somalia might say that really are there people dying because of excessive eating, and here there are people dying because of excessive hunger. So a dichotomous world that we all live in. So let's start. So uh, I did this 40-year-old male with severe obesity, BMI being 58.8. His complaints were discomfort performing his daily activities in 6 years, presumably from
Sir,
the.
sorry to interrupt. We can't see the slides.
Oh, uh, is it now? Are we able to see it?
सर आपकी स्क्रीन शेयरिंग ऑफ कीजिए और रीशेयर कीजिए सर.
Okay,
Now we can see.
Yeah, we can see, sir.
okay. So I think I'll just start like this. I'm really sorry. Okay, so everything was not visible, or just a few slides, or it wasn't visible at all.
There was a blank screen. Now it is visible.
Okay,
Yes.
so yeah, so this is a famous social activist, uh, sovereign activist, Hawaiian sovereign activist, who died because of obesity. He was very famous. He was called as Brother Is, and because of his comorbidities, at the age of 38, he died. He was around 350 kgs and 6 feet 2 inches tall, uh, and just because of his obesity, he died. So, as we know, that obesity is also a pandemic, like how COVID was. but that is less given importance. It is a disease.
Sorry to interrupt, but start the slideshow so that the slides will come one after the other.
Okay, ma'am. Is the window seen?
No, now nothing is seen. We see a blank screen.
Yeah, that is what when I'm sharing with the
Can see the slides now, sir.
Are you able to see now?
No, actually, then we'll continue as it is.
Yeah, can't see now in slideshow.
Okay, okay, okay. So I think this is how I'll present.
Okay, sir.
So obesity, as I was saying, is also a disease, and maybe the children in Somalia might say that really do people really die of excessive eating and obesity, whereas here they die of hunger. So there's a dichotomous world that we really live in. So what I did a case was 40-year-old male with severe obesity, BMI being 58.8 kgs. His complaints were discomfort while performing the daily activities, which increased over 6 years, probably from the time period of COVID. Chronic sleep deprivation, daytime somnolence since 1 year, and eventually he started developing shortness of breath and weight gain. So he was struggling for 6 years despite attempts of dietary modification, exercise, prescribed medicines for weight loss. He was still gaining weight, and his symptoms were increasing, like daytime somnolence and tiredness. And he could just barely walk at level ground with support. Met was three. Great discomfort on climbing the one flight of stairs as well. Eventually slept in sitting position since 2 years, and there was loud snoring, grade three, which his wife also complained, and a lot of nocturnal awakenings that he started experiencing. So according to the classification, so he was 58.8. So he was a super obesity category that he was categorized in. Eventually, he had swelling in the lower limbs, knee joint pain. He was put on dietary modifications like a liver shrinkage diet, where you put the patient on 800 kilocalories. There's a lot of protein in the diet and less of fat and carbohydrates. Medications these days which are approved like liraglutide, but it was unsuccessful, and so he started having this frustration. The anxiety increased, and then it started affecting his work and family life. He was also sent for a counseling session. Mm, he had hypertension as a comorbidity and hyperlipidemia. So his treatment history, past and history was not very significant. He was on amlodipine, telmisartan, rosuvastatin, and no any drug allergies. His mother had hypertension. So because of all these things, he was referred by his family physician to the bariatric surgeon, and with the consultation with bariatric surgeon, sleeve gastrectomy was advised to him, and he was given all the clear understanding of the risk and benefit of the bariatric surgery, and he actually consented to the procedure. So while his general examination, he was very obese. When he came to the OPD, he was walking with support, fatigue, bit drowsy, undergroomed, anxious. Vitals were like nine. Is all these vitals what we can see on the screen? And BP was on a higher side. SpO2 in the room was 93%. So nowadays we have these BMI calculators online, so you can actually calculate it. It was 58.8. His height was 175 and weight was 180 kgs. On his head and neck examination, he had little lid edema, mouth opening were two fingers of the patient himself, otherwise large tongue. Malampati was grade 3. The jaw protrusion test was, he was able to protrude it, and he had 5 centimeters of the thyromental distance, which is less. At least it should be 6 or above. Neck circumference these days is a predictor for difficult intubation. His was 44 centimeters, which was more than 40. Neck flexion extension were adequate, but he had short neck, and he had abundance of anterior neck region adipose tissue. Otherwise, no lymphadenopathy, pallar sinuses, and also he had tinea cruris. His respiratory system is very noisy breathing. Air entry at the bases were reduced. SpO2, as I said, was 93%. He was on BiPAP eventually 6 months before the surgery was planned. And the respiratory disturbance index was 28, grades into moderate OSA. So he had developed OSA. The stop bank score was more than that. As you can see, he had snoring, he was tired. There's observed breathing by the other person, blood pressure he had. So all these factors were taking him to a high risk of OSA. So we'll talk later about this Pickwickian syndrome. So he had those features of this thing. Pickwickian syndrome is basically OSA with cor pulmonale, and now it is called as obesity hypoventilation syndrome, a combination of it. So as we've covered all the respiratory system and cardiovascular changes that we get. So I'll just skip this slides. So he was referred to a cardiologist, and he gave a moderate cardiac risk. He accepted acceptance for surgery with this pulmonologist, and OGD scopy was also done by the surgeon beforehand. His lab investigations were done. ECG had a LAD, otherwise a normal sinus rhythm, and 2D echo was concentric LVH, grade 1 LVDT, and mild PH, pulmonary hypertension he had. The ABG gave the results of mild respiratory acidosis, and pulmonary function test done by pulmonologist was mild restrictive pattern. Polysomnography also was done by the surgeon, and he had moderate OSA. So we accepted the patient for anesthesia after all this profile under ASA classification 3 with due risk of anesthesia and cardiac risk. So patient was given the briefs of the risks and benefit. He is consented, and eventually explained about the fasting guidelines and the pre-admission before the surgery. 2 days prior to the surgery, he was admitted. Now let's go to the intraoperative management. So before taking the patient inside, of course, we confirmed about the NBM and consent. This is a positioning that we required to give. So head elevated position or ramped position that we say. So the ear to the sternal notch should be in one line, and the face should be facing the ceiling. So this is a good position to intubate. This is again the ramp position, face parallel to the ceiling. Also, we should take care about there should not be any ulnar nerve or any peripheral nerve injuries. So the proper padding and the level heading should be there while positioning. This is the intra reverse Trendelenburg position that the patient is set in. And more for monitoring for BP cuff, we can always use the wrist or a calf band because of the obvious reasons. Pneumatic compression device was also used. So what all I did was a wide bore IV access, 18 gauge and 20 gauge, which was okay. If central line and arterial lines were kept as a backup and with infusion pumps if required. Warming blankets. I intubated with video laryngoscope. I'll come to that. A difficult airway cart was ready. A flexible bronchoscope was kept ready. Tracheostomy set, and ENT surgeon was also asked for a standby visit, and another helping hand, another anesthesiologist and a technician was there, and USG machine was kept ready. So this is that patient. He was 180 kgs that we did. So induction, I used a pre-medication of glycopyrrolate and ondansetron. I pre-oxygenated the patient. A Dexmed infusion was started with 0.1 mic per kg or 10 minutes according to the ideal body weight. Pre-induction, after this, I gave midazolam diluted and fentanyl 50 mics I had given according to the total body weight, 0.5 mics, and the rest after intubation I gave. Ideally, remifentanil should be used, but it was not available at my center, so I had to use fentanyl. We did a non-invasive positive pressure ventilation for about 3 minutes while the capnography monitoring was on. And for induction, I used Sevofol. Propofol, I use 1.5 milligram per kg as opposed to 2 milligram per kg because I use sevoflurane at 2%. I did a check scopy first because the patient had short neck and the neck circumference was 44 centimeters. He had anterior pad of thickness. So for all these reasons, I preferred doing a check scopy. Then I gave, after positive ventilation, I did a give choline 1 milligram per kg, and with video laryngoscope we did the intubation. The Cook's modified Cormac-Leon score was grade 3. We used a Tripti blade, uh, and a bougie guided intubation was done. 8-number flexometallic tube could go, a railroad, and it was fixed at 20 centimeters. Otherwise, then for maintenance, we use atracurium at 0.7 milligram according to the ideal body weight. And then for maintenance, because we didn't have desflurane, we had to use sevoflurane. This is the position, reverse trending bug. So intraoperatively, the ventilation wise, intraoperative spirometry and flow volume loop are very important. So any changes that could happen during surgery, we could easily pick up. Volume, as ma'am also mentioned, volume cycle ventilation, then eventually you can, if at all required, we can use PCV. And PEEP around 8 centimeters was kept to avoid atelectasis. Fluid management wise, the latest articles of 220-24 BJ always say that we should keep a little positive balance so that we are not affecting the kidneys. So 4 ml per kg according to the ideal body weight. And blood loss was very minimal, around 150, because laparoscopically it was done. Peri-extubation, so we extubated the patient after adequate recovery from the atracurium, and we reversed it with neostigmine and glycopyrrolate. We considered postoperative BiPAP because the patient had OSA. Just to avoid hypoxemia, we kept him on BiPAP. And this is a semi-fowler position that you can see. This is very good for the patient for the proper oxygenation. Patient was fully awake, and we shifted him to ICU. We have an attached ICU setup. So prior only we had booked this thing, and with BiPAP, we had kept the patient overnight. So eventually the next day, the patient was quite comfortable. And as we all know, bariatric surgeries are highly emetogenic. So antiemetics were also given to avoid PUNV. Also, DEXA has a weak analgesic and a mild antiemetic action. So that was also given along with metoclopramide and MSET. The very important and less talked about topic is the postoperative pain. So what we normally do is we tend to give more of the NSAIDs and PCM, and also a few opioids as a this thing. But nobody talks about the uh, blocks which could be given, so that it's like a multimodal analgesia bouquet that can be created to reduce the pain, and then eventually the respiratory mechanics and everything improves, and the patient can be improved because the early ambulation and can be sent home. So what we did in this patient was interestingly an external in oblique intercostal facial plane block. Uh, so in the sleeve gastrectomy, you can see it could be a 3-port operative procedure or a 5-port. So everything that you can see is above the umbilicus. So for a external oblique interfacial plane block, what we can do is we block the uh, nerves, the anterior and the lateral cutaneous nerves, intercostal nerves at sixth rib. So this is the mechanism here. As you can see, the nerve is coming and it's bifurcating into a lateral cutaneous branch and an anterior cutaneous branch. The star here, which is shown, is the injection that is to be done. So just below the external oblique and above the sixth rib, we can place our local anesthetic, and it will easily slip down like a deep serratus anterior block, and it also goes ahead to cover up the anterior cutaneous branch. So this is the area that is covered where the port sites are there, and it gives a nice sensory block. Also, studies were done where cadaveric spread has been seen. As you can see here, the anterior cutaneous T6 to T9 was covered, the blue part of it, and the lateral cutaneous T6 to T10 part of it. So here on a sonoanatomy, you can see this is the seventh rib, this is the sixth rib, and external oblique muscle and the internal oblique muscle. And this is the injection that we did. This is the pleura, lung, sixth rib, and near the seventh rib, this is getting lifted because of the local anesthetic. The external intercostal muscle is getting lifted because of the local anesthetic. So if we see a cut section here from the xiphisternum, what you can see is the xiphoid process, the costal cartilage, and the intercostal muscle. This is the external oblique muscle, and this is the local anesthetic which is uh, injected here, and it will easily slip here because the rectus abdominis muscle is covered from the same sheath from the external oblique, and eventually the drug seeps through and also gives the effect of the rectus abdominis plane block if the volume is high. So volume around 30 ml on each side, 0.1 to 5% is also quite enough because considering it is a multimodal analgesia. People might say, why didn't you go for subcostal tap? But the problem with the subcostal tap is the anterior cutaneous nerve is only covered, and so this blue part only will be covered, and the lateral part, which is blocked when the lateral cutaneous nerve, intercostal nerves are blocked, is spared. So with the one which I said, external oblique intercostal facial plane block, we could have all these advantages because first and foremost in obese patients, it is very difficult to give a subcostal or tab block or for that matter QL block. So this is easy anatomy. It's like you're hitting the sixth rib, you're knowing the sixth rib is there. There's a bony backstroke, so there's no inadvertent injection that goes into the bowel or any other muscle. Even if catheter in pediatric patients also they put catheters, is easy. Also, the surgeons will not say that you are coming into my territory and there's chances of infection, and that is avoided. And no anticoagulation concern is also there. So the finally coming to the outcome that this induction was smooth with video laryngoscopy, slightly difficult intubation, but I did chexoscopy for that. We did have PEEP and low tidal volumes, minimal blood loss because of the laparoscopy surgery, and post extubation also with BiPAP. It was stable extubation, pain control was good with this covered block. No other significant post-operative complications, and the patient was discharged in 3 days. So, considering the takeaways, airway assessment is very important. Ventilation strategies behind are important. Calculating the doses BMI according to the BMI is important. A multimodal approach for pain management definitely is important. And early, which all will lead to early mobilization and reduced respiratory complications. And above all, a multidisciplinary approach with the surgical team, intensivist, nursing staff for the optimal care of the patient. And just a trivia, this I found a picture in US. Person was operated. This is the paniculus. They had to lift it with two huge hooks, and after this, the SpO2 started increasing, which was falling because of the whole load over the diaphragm. Thank you. Hello.
Thank you so much, Dr. Anis. It was a very detailed explanation of your case, very well planned and executed, sir. And the facial plane block you explained was excellent. Thank you so much, sir. After
Thank you.
these two very interesting cases, we have some questions coming up, which we'll quickly take in the next 5 minutes. I think one question ma'am has answered, Rashmi ma'am, that how much should be the dose of injection?
पहले मुझे सर इन्फॉर्म हुआ केस पहले मुझे
Please mute yourself. Okay.
Hello.
Yeah.
I'm not able to see you guys.
So one question, Dr. Rashmi has already answered it, but for all of us, what should be the dose of injection heparin as a DVT prophylaxis?
Hello.
Rashmi ma'am, are you there?
Am I audible?
Yeah.
Yeah, I have answered it in the chat.
Yes, ma'am.
Actually, somebody asked the dose of Clexin,
Yes,
enoxaparin.
ma'am. Yes.
So, enoxaparin is best given at a dose of 0.5 milligram per kg of total body weight. If you give it according to ideal body weight, the dose is too less. And if you
Yes.
give it according to the usual dose, that is 1 milligram per kg of total body weight, then the dose is too large and it leads to many bleeding complications. So in many papers, it is written that the ideal dose of enoxaparin is prophylactic dose is 0.5 milligram per kg of total body weight.
Yes, ma'am. Okay, ma'am. Thank you, ma'am. And one question: is stress to echo essential for all morbidly obese patients? Should it be done? Stress to echo.
I think it will be difficult to do the stress to re-echo in these obese patients,
Yes,
other than
ma'am.
whether it is mandatory.
Yes, ma'am.
That's what I feel.
Okay. So, Rajita ma'am, in your case, there was an intraarterial line taken for invasive.
No.
Okay.
No, CBP or arterial line was not taken
Yes.
because I had a good BP cuff was available, and because she did not have any kind of comorbidities,
Yes, ma'am.
so it was not indicated.
And ma'am, one question I think for your case again, or such a similar case, if you are doing, is color Doppler essential to rule out the DVT?
Yes, actually, yes. But this patient was quite mobile, being a
Yes, ma'am.
31-year-old young patient. That's why it was not, in this case, it was not done preoperatively.
Yes.
Of course, the DVT prophylaxis and DVT pump was used.
Yes, ma'am. Okay. Thank you, ma'am. So, as we saw, it is a morbid obesity is actually a metabolic syndrome and the coexisting comorbidities. So, as we move on, we now go on to welcome our next speaker. It is our honor to have Dr. Parna ma'am here. Welcome, ma'am. Ma'am will be talking on the risk stratification, the fluid management, and the dosing in morbidly obese patients. Madam is a consultant anesthesiologist at Sir H.N. Reliance Hospital. Madam is our very own SAM's newsletter editor. Ma'am has more than 160 publications to her credit. Welcome, ma'am. Over to you. Parna, ma'am. We'll just check.
Dr. Priyamvada, you want to call her?
Yes, ma'am.
Prana madam has actually logged in. Why is she not joining?
Yeah, ma'am is joining. Just a minute. Welcome, ma'am. Um,
Yeah, just 1 minute.
yes, ma'am.
Yeah. Okay. So I thought my lecture was after Dr. Kalpesh. So, okay, doesn't matter. Good evening, all. Greetings from Sir H.N. Reliance Foundation Hospital, Mumbai. My slides are visible?
Yes, ma'am.
Okay. Greetings from Sir H.N. Reliance Foundation Hospital, Mumbai. This is my department, and I'm the course director for Neuroanesthesia Fellowship Program. If anyone is interested in joining, please let me know. So coming to my topic, simplifying the complex risk stratification, fluid and drug dosing consideration in obese patients. So obesity is on the rise, and the average BMI in the Western population is more than 25%. The red areas in the map indicate BMI more than 40%. Now, we talked in the evening about preoperative assessment optimization, but along with that, risk stratification is very important to reduce the perioperative morbidity and mortality. These are the UK SOBA guidelines and seventh National Audit Project guidelines, which were published in 2024, and it emphasized on the preoperative risk assessment. Patients, it says that patients living with obesity were noted to have poor preoperative risk assessment and increase in the postoperative events. So, thorough preoperative risk assessment should be done. So, now let's see what tools do we have for risk assessment. So first is the age-old ASA classification, but that is only meant for eyeballing by the anesthesiologist. We also talked about BMI, central obesity. Central obesity is associated with higher risk. Then we talked about obstructive sleep apnea, stop bank scoring. Stop bank scoring more than 5 indicates higher risk. But all these are just the numbers. It doesn't tell you anything about the functional status of the patient. It doesn't tell you anything, whether it doesn't give you the whole picture about the patient. It doesn't tell you whether the patient has restricted activity, he's mobile, or he's wheelchair bound, or he's bed bound. Also, it doesn't tell you anything about the mental status of the patient. So, it doesn't, some of these patients are on antidepressants, and they are also on antipsychotics. Also, they have a lot of associated medical conditions. So these tools, they do not tell you anything about the associated medical condition, whether they are well managed with the medications or the end organ damage has already started occurring. So Edmonton obesity staging system is one such tool where all these factors are taken into consideration, and it gives you a real picture about the patient. So here, depending on the associated comorbidities, the patients are divided from stage 0 to stage 4. And it tells you also about the medical management, medical conditions of the patient. For example, supposing if the patient is hypertensive, then it tells you whether the patient is well controlled or he started getting end organ damage. So, yeah. So stage 0 and stage 1 are these patients who are well preserved obese patient. As earlier we saw that some patients are just obese without any associated medical conditions, and they are just obese and not, they don't fall into very high risk categories. Now, as anesthesiologists, we come across stage 2 and stage 3 patients, where these patients are have a lot of associated comorbidities. Also, the medical management is failed, and now weight reduction surgery is offered as a last resort. So, optimizing and risk stratification of the stage 2 and stage 3 patients is very important to reduce the perioperative morbidity. Now, Edmonton scoring system, it gives you a very fair idea about the perioperative morbidity and mortality, and it is one of the best tools which is available so far, and it predicts the obesity risk better than the BMI or the waist circumference. Also, it guides you to plan the surgery. So it also can guide you what kind of surgery should be offered to the patient. Supposing if it's a very high risk patient, stage 4 patient, then we can just do a small procedure like sleeve gastrectomy and make the patient comfortable. So it also helps you to guide the surgical plan, and it tells you when to not go ahead with an extensive surgery. Now, a lot of these patients where the medical management is failed, they would be also on these new anti-obesity medications like GLP-1 and GIP receptor agonists. Now, these medications, they act by increasing the insulin release and they decrease the gastric emptying, and thus it increases the feeling of satiety. The biggest side effects of these medications is that it causes vomiting, diarrhea, and nausea. So when these patients are posted for the surgery and they are taking these medications, they may already be dehydrated when they come to you. Although also as a part of preoperative optimization, a lot of these patients are on diuretics. So they may be dehydrated when they come for the surgery. So the fluid management is very tricky in obese patients, and it's like walking on a tight rope. And overhydration can lead to complications like pulmonary edema, tissue and bowel edema, and underhydration can lead to post-operative complications like acute kidney injury, rhabdomyolysis, and post-operative nausea, vomiting. So the aim is to always maintain U volume during the surgery. Now there are two schools of thought. Earlier it was thought that lots of fluids, liberal fluids, should be given to obese patients during the surgery to prevent rhabdomyolysis. But also there is restrictive approach where the lesser number of fluids, lesser amount of fluid is given, but goal-directed fluid therapy is highly recommended for these kind of high-risk patients. Now, conventionally, we guide the fluid therapy as per the blood pressure of the patient, urine output, CVP. So we use these parameters to guide the fluid therapy intraoperatively. But in these high-risk patients, as I told earlier, even the ERA Society recommends goal-directed fluid therapy. Now, this is a very interesting article which I came across in British Journal of Anesthesia. It talks about 5 T's of goal-directed fluid therapy. Now, it tells you, now let's see what 5 T's are. So first is goal-directed fluid therapy should be given to all the high-risk patients. So the target population is very important, and the timing of intervention. So we think that it should be given only during the intra-op period, but goal-directed fluid therapy should begin in the preoperative period, continue in the intraoperative period, and also continue during the post-operative period. This is the right way to give goal-directed fluid therapy. Now, target variables like stroke volume variation are measured and the goals are set. And the hypotension is treated with fluids, vasopressors, and inotropes. Now, let's take an example. Now, supposing during the surgery, your patient is hypotensive. So, you measure the stroke volume and you give the fluid bolus to the patient. After giving the fluid bolus, again you measure the stroke volume. If the stroke volume increases more than 10%, that means the patient is quite dehydrated and he needs more fluids. And he's on this steep part of the Frank-Starling curve. So the aim is to decrease the increase in the stroke volume to less than 10% and get the patient to this plateau portion of the Frank-Starling curve where he doesn't need too much of the fluid. So we give only as much as is required. So that is the goal-directed fluid therapy. Now, if you do not have invasive lines in place, then how will you give the fluids? Then you can see the plethysmography waveform, and that can help you to give the fluids. But if you do not have invasive lines, you can follow this. So this was a beautiful randomized control trial which was conducted in bariatric patients, and they gave liberal fluids 10 ml per kg per hour to one set of patients and 4 ml per kg per hour to another set of patients, and they found that smaller volumes of fluid may benefit the patient without adversely affecting the renal function. So always give less fluids and maintain U volume. Give as much as is required. Now, drug dosing. That is again a confusing, very confusing topic. These NAP5 recommendation, National Audit Project 5 recommendations, they say that obese patients are prone for accidental awareness. So obesity should be considered a risk factor for accidental awareness under general anesthesia, especially at induction when the rapid sequence induction is planned. So they recommend careful dosing to ensure adequate but not excessive dosing. Okay. So these are the NAP5 recommendations. Now, again, it gets very confusing whether to give the doses according to the total body weight or lean body weight or ideal body weight or adjusted body weight. Now, let's first understand what happens to the anesthetic drugs when they are injected. So when the anesthetic drug is injected, that time it gets distributed in 3 compartments. One is central compartment, which comprises of plasma, that's a V1. Then is V2, which is a vascular muscle compartment. And then the drug goes to a slower compartment, which is fat, um, fat compartment, and then it goes to the brain to cause its effect. So before reaching the brain, it gets distributed in the plasma, muscles, and then the fat compartment. Now, the anesthetic drugs can be hydrophilic or lipophilic. Lipophilic means they are attracted to the fat and they get distributed in the fat. So, anesthetic drugs are either hydrophilic or lipophilic. Now, supposing if I give a lipophilic drug as per the ideal body weight. So, ideal body weight doesn't take into consideration the fat component. So if I give a lipophilic drug according to the ideal body weight, then I'll be underdosing the patient. So sorry for this busy slide, but if a lipophilic drug is given as per the ideal body weight, then before it reaches the brain, it will get lost in the fat. So very little drug is given and now it is lost in the fat. So very little drug is available to act on the brain. So the lipophilic drugs cannot be given as per the ideal body weight. Whereas hydrophilic drug, it is okay to give as per the ideal body weight. But most important is watch for the clinical effect. So as you are injecting the drug, forget total body weight, ideal body weight. While injecting the drug, keep watching on the parameters, keep looking at the patient and give the doses according to the clinical effect. Now let's understand a little bit about the how fat is distributed in an obese and a normal weight patient. In a normal weight patient, the lean body weight is 80% and the fat is only 20%, whereas in heavy patients, the fat component is 40%. So when the BMI increases, that time the muscle mass also increases, but increase in fat component is much more than the muscle mass. Now, let's take this example. This is a 120 kg old, 120 kg patient and his height is 162 centimeter. Now, ideal body weight, how to calculate ideal body weight? Height in centimeter minus 100 in men. So, his height is 162 centimeter minus 100, that is 62 kg is his ideal body weight. Please note that his total body weight is 120 kg and his ideal body weight is half of his total body weight. So that is around 62 kgs. So whenever the ideal actual body weight is more than 30% of the ideal body weight, give the doses according to the adjusted body weight. So this is the formula for adjusted body weight. And here it's an interesting thing that if you go in the decreasing order of the numbers, the total body weight is always more. Then comes the adjusted body weight, which is around 84 kgs. Then comes the lean body weight, which is lesser number. So that is 68 and ideal body weight is the least number. So total body weight is maximum and ideal body weight is the least number. Now, the highly lipophilic drugs like succinylcholine, sugammadex, antibiotics, all should be given as per the total body weight. All the anesthetic agents, analgesics, non-depolarizing muscle relaxants are less lipophilic drugs. So they should be given as per the adjusted body weight, and the inotropes, vasopressors, can be given as per the ideal body weight. Inhalational agents, faster acting inhalation like sevoflurane and desflurane are preferred in obese patients. And these are the SOBA guidelines. Just for a quick reference, if you land up into a very obese patient and you need to plan your anesthetic. Thank you very much.
Thank you so much, Parna ma'am. Actually, a very complex topic, but you really made it simplified for all of us,
Thank you.
especially the drug dosing. Thank you, ma'am.
Yeah, thank you.
So as we come towards the end of this webinar, we have Dr. Kalpesh Shah, sir, with us. We welcome you, sir. Sir is a consultant
Thank you.
anesthesiologist practicing for more than 20 years. Sir is the director of Safe Anesthesia Solutions. And sir will be talking about anesthesia considerations for bariatric surgeries. Sir has more than 60 talks in various state and national level conferences. And sir was a secretary at MASCON 2024 Mumbai. And sir was a part of What Will Dr. Kalpesh Do? So that was an event well appreciated by all. And there was a full audience there, and we have it here too, sir. So over to you, Dr. Kalpesh.
Thank you so much. Thank you so much for the kind word. Good evening to everyone. And first of all, I would like to thank for the BSA organizers for giving me this opportunity to share my experiences. Let me share my screen first. Just a minute. I just reached to my first slide first. It's not going up. Let me do it again. Actually, before I start my talking, honestly, many topics which are extremely important are covered very well by all the speakers. So preoperative examinations, preoperative, 1 minute, it's not pausing. I'm getting something else. I should get to the first slide soon. Don't worry. Yeah, I reached here. Dr. Priyamada, madam, my voice is audible to you?
Yes, sir.
Okay, okay. So after all the stalwarts had spoken about preoperative evaluation, risk stratification, drug dosing, ventilator strategies, ventilation and extubation strategies and all, I have very little topics to talk about, but I would say that all those topics which I am going to speak are going to be extremely important for a practical purpose. I have a couple of disclaimers that all images are from the internet and all the images and videos are of my own patient. So I have taken the proper consent of them. I will be describing my own experience for the benefit of my friends, those who wants to establish any obesity surgery center, or they are starting getting a request from a surgeon that let us start doing obesity surgeries on a regular basis. And each and every small things which I have faced in my practice so far, I will be describing here. And I have no conflict of interest. The topics which I am going to cover about the pre-oxygenation. The most important thing when we are going for the intubation of such patient. Second thing is positioning during intubation, during surgery. Ventilation and intubation issues for the airway securing, intra-op monitoring and common issues with that. IV line difficulty and troubleshooting of that, and shifting of the patient and issues regarding. Dr. Parna madam has cleared this ideal body weight. As usual, we X minus 100, 105 or 100, which is absolutely clear from the Parna madam's talk. So I'm not going into the detail. Adjusted body weight, again, we know about that. Lean body weight, we all know about. There are complex formulas are there, and complex formulas can be managed on online available calculators also. Now, one more concept which I wanted to tell about, that is a normalized lean weight. The normalized lean weight is a proportion, uh, just- proportional to the lean body weight for the patient of all the height and weight, and is thus an appropriate weight scalar for the drugs and that are expected to scale according to the lean body. So if we simplify again, rather than going into the detail, this is a fact. This factor is 1.3 for a woman and 1.23 for a man, and which has to be multiplied to the lean body weight and calculate as all the parameters where you want to use it for the drugs and fluid management. Now, some about the bariatric surgery, most effective and safe treatment for a morbidly obese patient, particularly when conservative methods of weight management have failed, with established safety and significant regression of obesity-associated disease such as diabetes and hypertension. And actually, anesthesia made a lot of difference to the surgical outcome of the bariatric patients. There are two types of main surgery. One is restrictive surgery, that is
So
inflatable
sorry to
gastric band.
interrupt. The
Yeah,
slides are not changing.
slides are not changing. I can see my slides are changing. How about you?
No, sir. We
Now,
just see the first slide, adjusted
okay,
body.
you see the plus. Oh, I, so what I'll do is I'll stop sharing and then restart.
Yes.
Now I'll just. Can you see this now?
Yes, sir.
Is it changing? Is it changing?
Yes, sir.
Okay. Okay. So we talk about adjusted body weight and then lean body weight. There are complex formulas about the lean body weight available on the net if you want to calculate that. Normalized lean body weight. Now, normalized lean body weight, again, this is a factor, is 1.53 for a woman and 1.23 for a man, which has to be multiplied to the lean body weight. So first we have to calculate lean body weight and then multiply this 1.53 for a woman and 1.23 for a man, and you get a normalized lean body weight, which can be used for all the calculations. Bariatric surgery is most effective and safe treatment for morbidly obese patients, particularly when conservative measures of weight management have failed. With established safety and significant regression of obesity associated diseases such as diabetes and hypertension. And we all anesthesiologists, and with our own safe methods, we have contributed to the safety of these surgeries a lot. There are two main type of surgeries. One is restrictive, that is inflatable gastric band is placed around the small pouch of stomach to reduce the size of the stomach. And another is malabsorptive, that is Roux and Y gastric bypass, which we call as gastric bypass, or in a sleeve gastrectomy, or a biliopancreatic diversion. This is not, third one is not very common, but otherwise gastric bypass and sleeve gastrectomy is most common. Sleeve gastrectomy is again more common, and more complex patient, we use sleeve gastrectomy for reducing their quick weight loss for up to cover 40-50 kg, and then we can move ahead with the second stage of the surgeries. Now, preoperative assessment, as Madam said, that should look and identify and assess, optimize the treatment for hypertension, diabetes, heart failure, OSA, pulmonary hypertension, ischemic heart disease. These are the 6 things which we are generally trying to see preoperatively. Once preoperative is done, risk certification is done, counseling done, X-ray, everything is done, and now we are into the preoperative scenario, and we are into the pre-oxygenation stage. First and foremost thing for the private practitioners, those who are doing it, I would say that our preoperative management of this kind of patient starts 30 to 45 minutes before the surgical time. So adequate time preoperatively is needed for the optimum measurement and optimum optimization of the patient to actually start for the induction. Some physiological changes, as we discussed: decreased FRC in this patient, generalized low tidal volume, decreased compliance of the patient, higher oxygen demand, and high risk for atelectasis. Now, all these factors together result in a patient with obesity desaturating significantly sooner after the induction than a non-obese group. Now, this fact we all know, and that's why we want to emphasize on the pre-oxygenation of such kind of the patient. We all have a different kind of pre-oxygenation method. Say, for example, tidal volume breathing, Somebody must be doing one vital capacity breath followed by tidal breathing. Somebody is doing one single tidal capacity breath, 4 to 8 deep inspiratory capacity breath, which is very common in all our setting preoperatively for obese and non-obese patients. Extended deep breathing of up to 16 inspiratory capacity breaths. All these techniques are very, very common for normal routine patients, but because of the differences in this patient's population, obese patient population, this effectiveness of this pre-operative oxygenation is not really very great. And there we required a little more efforts to prevent, to give the pre-oxygenation to the patient. We all must be doing a pre-oxygenation for other normal patient by 5 liter, 6 liter or 8 liter or maximum by 10 liter of oxygen in a pre-operative setting or even for an obese patient. Now, pre-oxygenation in obese patient, reduced functional rate capacity elaborated by the supine position might decrease the effectiveness of pre-oxygenation and the tolerance to the apnea. The moment we put the patient in a supine position and they pre-oxygenated by that, this will not give an adequate pre-oxygenation to the patient. Study was compared the effect of body posture during pre-oxygenation, sitting or supine on its effectiveness in obese patients. So pre-oxygenation was achieved with 8 deep breathing with 60 seconds in an oxygen flow of 10 liter per minute with the nasal prong in a sitting position. So here the whole idea is to manage the whole idea is to manage the 1 minute. My screen is gone.
अमूल मस्ती दही बघू दाखव साईज हे समोरच
Others, please mute yourself.
See you.
लिहून ठेवतो
My screen is gone. मेरा जो स्क्रीन शेयर करवाना है Can you see my screen now?
Yes,
Yeah.
sir.
So sorry for the trouble. Now, so I was talking about a position. So the study has proved that in a sitting position, if the pre-oxygenation is done in a sitting position, that would be the best position to give a pre-oxygenation to the patient. That is also 10 liters per minute of 10 liters per minute of an oxygen flow. There are a couple of methods by which we do give oxygenation to this patient. One is a simple nasal cannula. Second is a nasal mask, nasal O2 mask with having a reservoir bag, or there can be a simple nasal mask or something like that. But nasal oxygen supplementation after a pre-oxygenation via nasopharyngeal catheter positioned to the nasal cavity with the tip of the catheter placed into the pharynx just near to the larynx is the most effective method if we want to see. Another way of giving it the pre-oxygenation is a RAE tube method. This preformed pediatric size RAE endotracheal tube is placed via the left corner of the mouth alongside of the wall of the buccal mucosa cavity. And the flow rate again with the RAE tube is a 10 liters per minute, and median safe apnea time was described in the one literature is 12.5 minutes, which is quite high is in case of the such kind of difficulty. This is how the RAE tubes can be placed. The curvature of the RAE tube itself will help to hold the tube while we are doing an intubation and without interfering into our oral cavity where our endotracheal tube and laryngoscope is going to be placed. Another very good method is a nasal CPAP method. Now, nasal CPAP is very popular in such kind of the patient where OSA and OSA symptoms are there. Many people are very used to with CPAP, BiPAP, and now they are using regularly nasal CPAP if they are accustomed with that. So nasal CPAP, continuing nasal CPAP during the surgery will also, during the intubation process is also one of the nice way to improve the pre-oxygenation of the surgery. This is a new device which was launched in the USA, but now it is available in India and not very costly, believe me. It is called Supernova, and this Supernova O2 tube is also extremely helpful, and there are literature saying that this is very helpful. Now, why we are doing all this thing during this surgery, during this kind of the patient, morbidly obese or a super obese patient, is that our goal during this entire induction process is to maintain the oxygenation. Many times we are confused. Many times our goal is to put a endotracheal tube into the right place. Right, endotracheal tube is the end point of a proper oxygenation with the proper method. But when we really want to see the entire process should have a good oxygenation. Without desaturation, intubating the patient is the biggest challenge for such kind of things. The most important point after the COVID, when everybody has started using this HFNO system, that is high flow nasal oxygenation system, this has come to the rescue in the operation theater for this kind of the patient, as well as any difficult intubation patient, where use of the HFNO as a pre-oxygenation method is very well recognized now. And so SOBAR UK also suggested that this should be used as and when required for an all morbidly obese patient. And here they have found that HFNO gives us a 14 minutes for intubation. This 14 minutes of apnea time is extremely helpful if we don't want to desaturate our patient during intubation process. Now, HFNO should be included in all obese patients as well as in anticipated difficult intubation to manage this. This HFNO is extremely simple device connected with the separate oxygen source. So when we are freelancing anesthetist going to the certain places, we should find out one separate oxygen outlet where we can really put in our oxygen pipeline over there. People have done this. This HFNO device has been used for all laryngeal surgeries where they don't use airway adjuvant, and then the TIVA and HFNO, and this technique was described as a Thrive. And we were lucky to use a Thrive because of the post-COVID, it was available in our hospital. So we have started using this high flow nasal oxygen device in our patients where their patients are obese for the obesity surgeries. Those patients who are taking preoperatively BiPAP on a regular basis, we should give that preoperative BiPAP or CPAP or BiPAP on a preoperative zone also and preoperative room also before we take them to the theater. Now, let us go to the actual airway management system. Now, actual airway management system, as we discussed, stop bank theory. Everybody discuss about the stop bank theory. With my experience of OSA surgeries, I would say that if my patient gives me history of observed apnea by relatives and they are not on CPAP or BiPAP for the various reason, most common reason is non-compliant patient. So I would be more worried about those patients because those patients desaturate very fast with the minimal dose of my sedatives. So I am very, very particular about giving a pre-oxygenation to this patient and readiness for the intubation as a quick RSI measure. We all know, as previously the speaker has described about the position ramping of the allows balloon, but I would say that this requires an extra efforts for an anesthesiologist, especially our freelance anesthesiologist, to create this scenario in the operation theater. So please be prepared for this. We all know that tragus and sternum should be into the same position, and there is a ramp position. There are separate hand support is also available into the market, and it should be easily available in operation theater. I was very impressed by using this technique. This is called Whelan and Kellicott position, which is a very old method, but I would say that slight extension of the neck, if possible, if the neck circumference is okay to manage, and a 25-degree head up position, and with a slight extension of the head during the intubation makes the entire process as well as pre-oxygenation and intubation very easy. The even recent guidelines in a recent article into the ISA has published that 15-degree head up position during the intubation makes the intubation very easy. Yes, as we discuss, all these patients are difficult ventilation rather than difficult intubation. So difficult ventilation, we all know that a nasal airway works fantastic. So my first thing when I reach for such kind of patient is a preparation of nose. That is Otrivin drops in both the nostrils. Prepare the nostrils just 5 to 7 minutes before the surgery. and see that the nose is properly patent. Use the nasal airway as much as possible from the beginning of your sedation process. Oral airway, mask holding with the two hands. Again, two hand and thumb technique is very, very important to understand where is the leak from the mask. Different category of face mask are also important to have in the operation theater to fit into the anatomical shape of the patient's face. And last thing, as Prajakta did in her case, that is an LMA. Ventilation via LM is a beautiful method to do it, and even our all OSA patients and even all pediatric patients, intubation, extubation, we do very often with the LMA. I would be very honest that Procil LMA is one of the best in the class to prevent any kind of the trauma when the LMA use is warranted in such kind of the cases. There is one more specific mask which has been designed, that is for CPAP mask, and this we are using pre and post of both. Now, this mask has a clear opening on the face, and this gives a 7 to 10 centimeter of H2O of CPAP during the positive pressure, during the pre-oxygenation, and immediately after the surgery. And this will be a very useful device, very well tolerated by the patient, and not very costly. Again, now we come to the intubation process. Now, as we know that intubation is an end point of entire airway management, and I would say that if patient is anticipated difficult intubation by all the criteria, more than couple of criteria are saying that is anticipated difficult, I would say that I would love to use a video laryngoscope as my first shot, because I want to avoid multiple attempts to minimize the risk of aspiration, risk of desaturation, and risk of hemodynamic disturbances in such kind of the patients. And to master the technique, I urge my all the juniors that practice video laryngoscopy in a normal patient at least 50 times. So in case if you have a difficulty in intubation, and as a algorithm, difficult intubation algorithm, second step is to use video laryngoscope, but you should be well aware about your video laryngoscope and how to use your video laryngoscope has to be practiced before you reach to the difficult intubation scenario. We all have a different variety of video laryngoscopes available, but I would say that all are useful, but the commonest are the most useful one, which we are master the technique. So master the technique where we can easily visualize the larynx and easily visualize the vocal cord at a different angle rather than doing with the regular length. But I would say that it is not that video laryngoscopy is only advocated. Intubations are not really very difficult in such cases, especially in a female patient. Intubations are not really very difficult. Male patient with a heavy jaw may give you a trouble for an intubation, but combination of regular laryngoscope with the video laryngoscopy skills is a very good way to tackle this kind of difficult intubation scenarios. In our practice, we are using this BPL video laryngoscope, and we have a couple of times we have used check video laryngoscopy under sedation before giving a relaxant to be very sure about the visibility of a vocal cords. So this is just a method which is becoming more and more popular nowadays. We all know that airway management decision making in such cases are very much protocolized now, and DAS guidelines and all this thing has clearly said what to do and what not to do. But we have to clearly understand which patient requires an awake intubation before we plan. So this is an algorithm by which you decide which patient requires an awake airway management. And in case of a difficult intubation, we have all armamentum about putting in a supraglottic airway devices or in a video laryngoscopy or in a front of neck access as per the DAS guidelines. Now, some important topic about OT equipments needed. Now, OT equipment needed, this topic I have specifically taken because from the nursing homes, small nursing homes, we have moved to the mid-size hospitals, and now mid-size hospitals started doing an obesity surgeries. So when they start, it is our department's importance that how you involve in the decision making of the equipments. So OT table for an bariatric surgery is an extremely important, which is a capacity of 300 kg minimum if they actually ask for a bariatric table. So whenever they suggest something, we'll have to have a plan about the bariatric surgery and looking at the OT table's capacity. Look at the base of the table also. Some off-centric tables are very, very problematic. And to be very honest, I am a witness of when table broke from the middle line I broke into the half piece because it was an off-centric and it was a 120 kg patient was. trying to be kept at the lithotomy position. So imagine 140, 150, 170, 180 kg patient is on this table and this table topples about it. I have seen one patient trolley is actually toppling with the heavyweight patient. So I am very, very concerned about these issues. Extra belt to hold the legs and hand and chest of the patient. Support to prevent sliding of the patient from the table during the head up position is extremely important. This is the position in which they do sleeve gastrectomy or an gastric bypass. So we have to be very, very careful about the sliding patient down with the endotracheal tube inside the place. Now, various size of the NIBP cuffs, wrist BP monitor, extra pillow, ramping for intubation, and video laryngoscope difficult card with adequate manpower and a PIS monitor. This is how our OT staff tries to do the extra work to get the table extra width with the two extra side arm so that the patient's extra fat pad can be accommodated into the OT table. These are the leg extra padding about near the legs. And this is how they are tying their hands and trying to take care of the hands to not patient should not slip down of the operation theater. This patient is this patient was our 268 kg patient and was not able to move from the bed to the OT table also. And you can see there are 10 operation theater assistants also are looking at him how he will move from a bed to OT table. So this is very crucial to understand this. And as we discuss, forearm BP cuff is an adequate, not ideal, but adequate way of measuring the blood pressure to get a rough idea about pre-op, intra-op, post-operative comparison of the blood pressures, or in a wrist BP cuff monitors are also available in case of any difficult situations. Role of central line and arterial line is very much limited, but I would prefer to put an arterial line in many situations, especially when I am doing a more than 2 or 3 ABG measurement of a patient for my intubation, extubation, and postoperative management. So putting a one radial arterial line will serve my intraoperative purpose, as well as I will be able to do ABG as per my requirement for first 24 hours post intraoperative as well as first 24 hours of postoperative time. Role of central line is really very limited because unless and until we have a cardiac patient or a low ejection fraction patient or in a patient with high pulmonary pressures or a other comorbid condition, we try and avoid central line. But this 268 kg patient, we had to put central line also because that patient had a lot of peripheral vascular diseases and no good veins were visible. So putting a central line for some time for a non-visible vein is also a reason for putting in central line, but it is not very regular. It is just for putting in just for a fluid management. Now, intraoperative hemodynamic control can be achieved by the use of combination of drugs like drugs which has been discussed by Parna and all. But then I would say that dexmedetomidine is one of the drugs which I like to use during the surgery if I don't have a remifentanil. And beta blocker NTG are sometimes very handy and very useful to manage the hypertensive response of a laparoscopic surgery or a pneumoperitoneum. Remifentanil, of course, is the most suitable opioid. Otherwise, we try and avoid opioid for such kind of the patient. But to be very honest, intubation response prevention, one dose of 100 to 150 microgram of fentanyl is used without any midazolam uses along with the propofol, so that our intubation response is managed little well. Desflurane and remifentanil, these drugs lend themselves very well for an obese population because of the minimal accumulation into the fatty tissues, with some evidence for the use of desflurane as an agent of choice. And we are using, and we are actually very happy about the desflurane uses. The most important point of a difference between desflurane and sevoflurane here is a patient's airway reflexes immediately after extubation is extremely well maintained by desflurane as compared to the sevoflurane. Maybe this difference is not more than 20-25%, but yes, the airway reflexes are extremely well managed by the desflurane post-operatively, post-extubation. Again, we discussed pain relief, paracetamol, diclofenac, and a tap log under vision by the surgeon if surgeon is very well versed about it, or otherwise USG guided tap block, or in a 4 point tab block where bilateral subcostal tab block along with a classical tab block on both the sides can be a good option, and it is sufficient. So these patients are not having an extraordinarily pain immediately after sleeve gastrectomy or an immediately after a gastric bypass surgery. So it can be managed by these three methods. Hypnotic stability assessment monitor is only one monitor which is available very easily. Is a BIS and BIS equivalent monitors about SED line and all, which is promoted by the Masimo's company. But we are very happy about using a BIS monitor. As we discussed, Dr. Aparna has discussed that propofol, the use of the propofol or the awareness during the intubation and RSI is most common. So our protocol for this kind of patient is putting in a BIS monitor before we start the sedation, and then propofol is given under the guidance of BIS monitor and hemodynamic monitoring. No doubt, hemodynamic monitoring is more important than the BIS monitoring, but hemodynamic monitoring and BIS monitoring goes hands in a hand. So patient should not have awareness during the surgery. One more point intraoperatively regarding the AGM and BIS monitor. If we have an AGM and BIS monitor, I would still love to have a BIS monitor for an obese and morbidly obese patient, because hypnosis is something very well managed or very well understood by the BIS monitor rather than an AGM. Now, AGM is we have a calculation and we have a rough calculation about each and every patient, like end-tidal sevoflurane concentration of 1.5% will tell you that patient is not aware. But then a lot of adjustment is needed in that end-tidal sevoflurane concentration, what we discuss about the fat percentage, height, body weight, BMI, lean body weight, normalized lean body mass, everything is needed, which calculation is not there. So hypnotic stability index is maximum taken care by this BIS monitor. So intraoperatively, BIS monitor is highly recommended. Articles and papers are very much in favor of this monitoring, the way we observe the brain activity. And certainly a good purpose is to have a standard of care as a BIS monitor in the future for obese patients for any surgeries, not only the obesity surgeries. One more point to discuss: the laparoscopic insufflation pressure in a pediatric at certain time it is higher 15 to 20 minutes of Hg than a usual. But pressure control ventilation with titrated positive and expiratory pressure to minimize saddle volume for a given pressure and minimize intraoperative postoperative atelectasis with monitored neuromuscular blocking it's an ideal practice. But at the same time, volume control measurement with the PIP of 5 to 7 and intermittent recruitment maneuver works very well. In practice, steep reverse Tenenberg position used for bariatric surgery mitigates the effect of pneumoperitoneum on ventilation to a certain degree, unlike the gynec laparoscopic surgery where we give steep head low position. So here we have a one point which is good in favor of us for this surgery. Special attention efforts are needed to avoid unnecessary attempts, and central line putting is for the difficult IV line. People, you may say that difficult IV line is not the topic to discuss because we all are masters about the difficult IV line. Our two best armamentum for an anesthetist is IV line and endotracheal intubation. But I would say that I have spent 30-40 minutes to find a good IV line in a obese and super obese patient. So I stress on this topic very much, that difficult IV line management is to be done and it has to be taken very, very seriously. There are certain methods by which we dilate the vein, that is positioning the patient's arm below heart level or letting it hang down the bed for some time, warming the skin by gentle rubbing or stroking, covering the patient's arm with a warm towel, applying heat to the arm, or encouraging the patient to open and close. We all do that, but beyond this, double tourniquet technique. So apply one tourniquet above the elbow, and then release and then apply one more, then release it, and then apply below that tourniquet one more tourniquet, and this will increase the blood flow, and tissue ischemia will release the histamine, and this will give a good vein visibility in case of the difficult veins. Vein finders, I was very enthusiastic about this initially, but then I would say that the amount of hype this instrument has created has not served the purpose. and we are not really getting, I mean, very high-end vein finders yet. So I don't have very high-end vein finders. So this 2,000, 5,000 rupees vein finders are not really helping us a lot in finding difficult veins. But these are the two unusual sites which we have sometime cannulated if we are lucky enough to do this: external jugular and cephalic vein. Of late, we started using a USG guided for the insertion of the vein. So anatomy of the veins are extremely important to understand, and the practice for the USG to identify the good vein is very, very important. Longer IV cannula than the regular IV vein flows are now into this experimenting and having a good results. They are made for little deeper veins, and probably by using a USG guidance. And this will stay for almost, they claim for more days, but they can stay for more than 7 days very easily. And this will help us in a management of the patient for intraoperative as well as postoperative. I think it's dinner time now. And last thing is, when size matters, we have to plan all the equipments as per the size of the patient. So when we are thinking about such kind of managing such kind of the patients, equipment, and equipment, orientation, acquiring the equipments and availability of equipment is an extremely important. Thank you so much for giving me this opportunity. Thank you.
Thank you so much, Dr. Kalpesh, sir. Sir, a very practical points and a lot of take-home messages for all of us. Sir, one question here, sir. The role of Thrive in pre-oxygenation.
Yeah. So role of Thrive, I mean, typically Thrive, we are not targeting 70 liters per minute, but what we are using regularly is a 40 liters per minute. The cannula which is provided by this is having a slightly larger bore and very, very soft. So because of the humidified oxygen and it is 40 liter through this cannula, patient really tolerate this 40 liter of oxygen very well. And 3 to 4 minutes of this oxygenation preoperatively works very, very well. And we continue this oxygenation during our process of intubation also. So that time also patients are getting oxygen.
So one question, it might sound a little silly. So does this affect does it cause fogging on the video laryngoscope?
Yeah. No, it doesn't fog. It doesn't fog because it is humidified. If
Yes.
you give higher oxygen without humidification, it may cause.
Yes. Thank you so much, sir.
Thank you.
Sir, all these steps, if taken adequately and meticulously, it will go a long way in preventing the morbidity in super obese and obese patients.
Right.
I would now hand over to Dr. Kalpesh Gaitonde. He is our Honorable Treasurer, ISA Borivali, to conclude this webinar.
Hello. Yeah, am I audible?
Yes, sir.
Okay. The most easiest part of the webinar today is the Thanksgiving. So I myself, on behalf of the office bearers of ISA Borivali, myself, Dr. Kalpesh Gaitonde, Honorary Treasurer, would like to take this opportunity to thank, first of all, the SAMS office bearers and the SAMS for giving us an excellent webinar platform, and Genka Technologies, especially Ganesh, for a seamless and uninterrupted conduct of this webinar. Most importantly, Dr. Priya Deshmukh, today's MOC, for conducting this webinar in a crisp and uninterrupted and seamless manner. She's a flag bearer of UA, ISA, UA from BSA, UA members, and yet another great performance from her. The speakers for the day, Dr. Rashmi Vaimbe, Dr. Shilpa Tivaskar, Dr. Anis, Dr. Prajakta, Dr. Kalpesh Shah, and Dr. Parana Takkar. Thank you for taking valuable time and gracing us this occasion for conducting the webinar. And last but not the least, our speakers for your cooperation and attending this webinar. I thank ISA Borivali and SAMS again for giving us this opportunity, and we look forward to more such academic events. Thank you very much.
Thank you.
Thank you.
Can we close the webinar?
Thank you for this opportunity.
Thank you, everyone. Thank you.
Thank you,
Thank you.
madam. Thank you, sir.
Thank you.
Bye.
Thank you,
Bye. Thank
ma'am.
you.
Bye.
Bye, ma'am.
Right.
Thank you for the opportunity.
फाइनल मिळालं का सगळं थोडं हा मिळालं जे इम्पॉर्टंट होतं सगळं MMC point will be directly up.